So, 4, 3, 2, 1, we are live.
Good evening, everybody, and thank you for joining us on this fourth session out of 5 of the 4th annual Indo-US Hand Surgery Conference. Thanks to COVID, we are going to be virtual this year, and it's every Saturday in May at the same time, 8 p.m. Indian Standard Time. Our theme for this year's conference is Common Conditions in Upper Extremity Surgery, How I Do It. And today's session promises to be really lively. It's going to be expertly moderated by none other than Sudhir Warrier from Bombay. And he's got a superstar faculty with Binu Thomas, Ruby Grewal from Canada, and Sumedh Talwalkar from the UK, as well as Becky Nidesky and Chuck Cassidy from the United States. So it's really a fantastic faculty, and they promise to make it very lively. No punches will be thrown, of course, because we are virtual. We must thank our sponsors, the Wyss Medical Foundation, the Deshpande Foundation, the Venous Safety and Health, and last but not least, the Indian Society for Surgery of the Hand. This effort would not be possible without the wonderful efforts of OrthoTV. I am going to hand it off to our today's session moderator, Sudhir Warrior, who will also alert you to how to ask questions because we want all your questions. Sudhir?
Thanks, Chai. It's been really 3 weeks of very, very wonderful discussions on the hand and wrist. And today we are going to be speaking more about wrist afflictions. To start it off, may I just remind you that if you scroll below your video, there is a Slido link which you can ask your questions on. So as you get the questions in your mind, just scroll down, put the question down, and Dr. Anil Bhatt and Dr. Rohan Habbu will be taking those questions and relaying it to the speaker. We start off with fractures of the scaphoid, one of the most common carpal bone fractures. And to tell us about the acute scaphoid, I would like to invite Professor Binu Thomas, who heads the Hand and Microsurgery Department at CMC Vellore, the Paul Brand unit, one of the most prestigious hand units in the country. And apart from being a wonderful, wonderful surgeon and a great human being, he's mortally afraid of diving, but he loves scuba diving. Binu, dive into your topic.
Ashok, can we start? I mean, Neeraj, can we start the first video, please?
Yes, please start. Jagan?
Greetings from CMC Vellore. Thank you, Chai. Thank you, Sudhir. Today, I'll be talking on scaphoid fractures, imaging and role of acute fixation. There are a lot of statistics, but most importantly, 20 to 40% of scaphoid fractures are radiographically occult. That means they're not visible on the primary X-ray. Coming to the role of imaging, there are a few questions to be answered. When I see a patient who had a fall on an outstretched hand with pain in the wrist and tenderness in the anatomical snuff box, what X-rays do you do? This is the scaphoid series, which is routinely done. It consists of 4 views, a true PA lateral, an ulnar deviated view, and a semi-pronated view. On the X-rays, what do you assess? If there is a fracture visible, then look at displacement. More than 1 millimeter suggests an unstable fracture. Comminution, perilunate injury, and proximal pole fracture are all unstable. So if you see a fracture on the X-ray, then CT scan is the next investigation to be done to assess the fracture and plan surgery. It allows you to assess the displacement correctly, comminution, and also on follow-up, it helps you to look at healing. One thing is the scan must be in the long axis of the scaphoid to give you the right information and not in the wrist. And you must ask for at least 1 mm slices. It has been found that X-rays are not good to assess healing, especially at 8 to 12 weeks. And in this situation, Singh et al. Described that the CT scan is recommended at 12 to 18 weeks. In the CT scan, you have to assess healing, the amount of healing that is based on the circumference. Partial union less than 75% requires a repeat CT scan. Now, whenever they find that the healing was more than 25% on a CT with protected immobilization, the scaphoid went on for healing. On the other hand, when cystic changes and resorption of fracture line was seen, they all became non-unions. MRI is a gold standard to diagnose radiographically occult fractures. So if you're in doubt about a fracture, go for an MRI. It also helps you look at avian and ligament injuries. The T1 weighted images is what you look at to see a fracture line, while a T2 with fat suppression shows bone marrow edema clearly. If the bone marrow edema is absent, then there is no fracture. As you can see in this series, the X-ray is doubtful. So a sagittal T2 with fat suppression shows a linear bone marrow edema, while the coronal T1 weighted image does not show any fracture. So the diagnosis is bone contusion and can be treated as such. Is there a role for ultrasound in assessing scaphoid fractures? Meta-analysis say that is a very accurate investigation and cost effective than empiric casting if CT and MRI are not available. But it is not a very reliable option according to Moran. The management of acute fractures. Few questions to be answered. Is there a role for empiric casting? What are the indications for acute fixation? Dorsal or volar percutaneous, or when do you do an ORIF? Let's look at the role of empiric casting. This study in 2004 reported that follow-up X-ray after 2 weeks or 3 weeks cannot be considered a valid diagnostic examination to detect scaphoid fractures when the original X-ray is normal. So there goes the old adage that you can put a cast for 2 weeks. Same thing, the SMART study that is ongoing in UK suggests that there is significant advantage in both cost and morbidity to the patient when immediate advanced imaging such as MRI or CT is done. So to avoid empiric casting. Coming to acute fractures, these anatomical classification tells you which fractures are likely to unite by cast. The distal pole and the horizontal oblique fractures of the waist will generally heal with casting, while the transverse fracture, vertical oblique, and the proximal pole may not unite and may be advantageous to plan for fixation. The cast treatment indications are these: stable fractures and uncomminuted fractures. And it takes about 6 to 20 weeks to heal. As you can see this, what type of plaster you give does not matter as long as you immobilize for the adequate duration. Fixation indications, the absolute ones are displaced fractures, comminuted fractures, and open fracture. That is any fracture that is unstable. And associated injuries such as distal radius fracture, ligament injuries, and complex carpal injuries. Relative indications include proximal pole fractures and the non-compliant or high-demand patients. With the advent of any number of annulated screws, we've started doing percutaneous fixation much more, with the advantages that the exposures are limited, immobilization is shorter, early union and early return to work. Most important thing to be careful is the guide wire should be in the central scaphoid axis, as I can see in this radiograph. Percutaneous screw fixation is evolved to be the standard of care in acute scaphoid fracture, at least in the Western society. The dorsal technique described originally by Slade, the guide wire is introduced just distal to the Lister's tuberosity, and it goes in the line of the thumb, mind the EPL tendon. There are some interesting techniques of C-arm imaging. First, the wrist is kept in neutral when the scaphoid is shaped as you can see like a boat. And when the forearm is pronated, it becomes cylindrical and then the wrist is flexed. You see the end-on view of the scaphoid. And then you may make sure that the guide wire is in the central scaphoid axis. This is a short video of how we do the technique. The C-arm is kept parallel to the hand table, and the forearm again is pronated and then flexed to see the end-on view. And there you can see the cortical ring sign. So at this point, do not extend the wrist. Once you drive in the K-wire, and once the K-wire is fully in and confirm that it is in the central axis, what you do is you go for withdrawing the K-wire from the volar side, so that you can straighten out the wrist and measure the scaphoid like this. And then once the scaphoid is properly measured, you drive back the K-wire and then introduce the screw. Here's a patient, 15-day-old injury. You can see the fracture. At the end of 60 days, the fracture line seems to be, there will be more resorption. So we decided to fix this fracture. And after dorsal percutaneous compressive fixation, patient went on to heal uneventfully. In the volar percutaneous technique, the wrist is extended and supinated. The scaphoid axis is marked on the skin under the C-arm imaging using a guide wire. The point where the both lines meet is the entry point of the guide wire on the scaphoid. A stab incision is made and the guide wire introduced again under C-arm guidance in the direction of the lines drawn, and the central placement of the guide wire is confirmed. This is the most critical step in the procedure. The screw measurements are then taken and a 4 millimeter shorter screw is used and carefully introduced. Avoid distraction by purchase into the distal segment. Confirm screw position in multiple C-arm views. Now, should I use a dorsal or volar approach? The type and location of the fracture dictates the preference. However, all proximal pole fractures being closer on the dorsal side, dorsal approach is preferred. Unstable fractures are best fixed by a dorsal approach according to Moran in 2009, and that is both B1 and B2 type of fractures, the Herbert. One study suggests that the central axis placement is easier with a dorsal approach, but I would leave it to individual surgeons to find out which is easier for them. Complications and healing, 89 to 100% union rates have been reported, but the complication rates are very high. Here you can see an avian, and there is a definite learning curve. Coming to the open fixation, again, approaches different, volar or dorsal, and is usually done when percutaneous fixation is not feasible or for other situations. That's a dorsal fixation. We use sometimes open fixations whenever we have to have other additional fractures, as in this patient, like a Smith fracture, or here the proximal pole fracture, we could not put a screw in and ended up with a K-wire. And in this open distal radius with scaphoid, we have again treated it open and addressed with K-wires, as you can see in this X-ray. What about the role of arthroscopy? We don't routinely use it, but there are people who are routinely using it for all percutaneous scaphoid fixations. I think the most important thing is to confirm a protruding implant if you are in doubt. That is an indication for arthroscopy. To conclude about scaphoid imaging and fixation, do MRIs when the radiographs are negative. CT scans are useful to plan management. Empiric immobilization should be reconsidered. And percutaneous fixation is evolving to be the standard of care. Thank you very much.
Wonderful beginning to a great evening. Thanks, Binu. That was very, very eloquent about almost all the questions that normally arise when you're dealing with an acute scaphoid fracture. Which ones do you choose to operate? When do you choose to operate? How do you look at them? What investigations would you do? And what approach you would take? And of course, the technique. So absolutely wonderful. Anil and Rohan, any questions?
No questions right now.
Right.
No questions on Slido.
Yeah. So if any one of the participants has questions, please scroll down. Below your video is a Slido link. Please type in your questions so that we can answer them. Because each topic is going to be a little different, so it's more relevant if they are discussed right after what has been discussed. So we go on to the next talk. Yes, Rohan.
Dr. Warrior, one question. There was a little confusion about what would be a higher imaging, whether to do an MR or a CT scan. Like Dr. Binu said, both for two different indications. So do we need to do both or only one?
Binu, would you like to? You need to unmute yourself.
Yep. As I said, the indication for each of them are slightly different. If you see a fracture, then a CT is a better investigation because then you can assess whether you need to fix it or not. That is, look for displacement, comminution, and all these. The information you get from a CT is better when you have the fracture already visible on your X-ray. But if you're in doubt about the fracture, then an MRI is a more sensitive investigation to see if differentiate a bone contusion from a fracture between the T1 and T2 images, as I mentioned. So if you're in doubt, go for MRI as your primary investigation. Now, I don't think that there is any harm in having both, but probably you don't require it if you don't have a fracture seen. Then an MRI is important, while CT is not, because it definitely is not going to be a displaced fracture when you cannot see the primary fracture on the X-ray. So that is it.
Okay.
Sudhir,
Yes.
I think that's a very valid point that Binu just made. And the same question was posed to the American College of Radiology, and they came up with a appropriateness criteria from 1 to 9. And for a fracture that is there but can be seen occult, hands down, they gave it criteria number 9 for an MR. So if you can't diagnose it on plain radiographs, don't waste time, get an MR and move on. And I think Ruby had done some work on that, right, Ruby?
Mostly on CTs, but yeah, I would agree. So MR would certainly be more sensitive if you're looking for, early edema changes and bone marrow abnormalities to identify a fracture that's hard to see. But if you know the fracture is there and you're wondering about displacement and you're trying to make treatment decisions, then CT would be my advice.
Yeah, I think that's what.
Yes, Rohan.
Yeah, we have two quick questions from the audience. When doing, this is for Dr. Binu Thomas, when doing percutaneous fixation from the volar aspect, is there a trick to go into the center of the proximal pole? Is there a surgical trick?
Is there a surgical trick about the center of the proximal pole?
Correct. When you're approaching it from the volar side, you're entering into the distal tuberosity. So
I think your entry point is very important in that situation. The entry point being radial volar allows you a better purchase to go into the proximal pole. And then the other thing is, we usually keep our index finger of one hand on the Lister's tuberosity. So you also roughly know where exactly the wire is pointing. And that gives you almost good, indication of where your guide wire should go. So these are the two techniques I use to make sure that I go to almost the center of the proximal pole.
Anyone else with?
Sure. Can I make a comment?
Yes.
So one thing I do is I use some sterile Coban, the wide Coban wrap, and hold the thumb and the wrist in extension like that so that the image is consistent. And it also exposes the scaphoid a little bit. And then I start by inserting it into the trapezium, the guide wire, because once you make a pass into the scaphoid, it's very hard to redirect it. So you get a sense of where the trajectory is before you commit to putting it into the scaphoid.
So you would go through this trapezium into the scaphoid for
Yes,
for all your volar approaches.
Well, I think it in part depends on the orientation of the fracture and the location. But for the typical waist fracture, I will start at the lip of the trapezium, where there's actually a little bump, and you can catch the bump and not slide off. The problem is if you start in the scaphoid, you may end up being too volar, and you're driving it much more dorsally. The only other aspect of it is if you use a depth gauge and you're going through the trapezium, you need to use the method of subtraction with a second wire rather than the depth gauge, because the depth gauge won't make it all the way into the scaphoid, and you'll be incorrect in the measurement.
And you would drill the cannulated drill through the trapezium as well.
Yes,
And
I think right, exactly. Some surgeons will take a rongeur and take the little bit of the volar lip of the trapezium, but you could do the same thing with the drill.
May I make a comment, Dr. Warrier?
Yes, go on.
Yeah. So just to get the direction perfect to hit the center of the proximal pole, with a 1.1 millimeter guide wire, which almost is a standard guide wire size for most cannulated screws, controlling direction may not be very easy. So one of the tricks is to drill with a stiffer 1.6 millimeter wire. And once you have gotten the track correct, then I simply replace that 1.6K wire with a 1.1 millimeter guide wire by hand, inserted like through the pre-drill flute. With that, perhaps I get a better control over the direction. I find it very difficult to get the control over direction with a 1.1 wire.
Yeah, in any case, you're going to drill it with the cannulated drill, so the size difference doesn't really matter.
Amit Gupta makes a good point about another trick, and he uses a 16 gauge needle. And I don't know whether he extends the wrist. I'm petrified of extending the wrist. So I can do all my scaphoids polarly with the wrist at neutral, because I'm deathly scared of the tension in the radius scaphocapitate ligament, depending whether it's type 1 or type 2, whether it's going to displace my waist fracture. So I just keep it at neutral, as Herbert used to do it. But I use Amit's trick, where you take off, like Chuck said, rongeur the foot plate of the trapezium, put your 16 gauge needle, and then use that, like Pankaj said, as a guide for your guide wire. Sumedh has a question.
There's one question to the audience as well from Dr. Nilesh. Should one worry about loss of reduction while dorsal percutaneous screw fixation? Binu?
Yeah, that is, at least theoretically, that is a possibility, because you are flexing and pronating the wrist. So which is the opposite of what we normally do to reduce a scaphoid fracture. But, technically, I have not really come across any loss of reduction by doing this step. So, but theoretically, it is possible. And if you are in doubt, you have to, withdraw the K-wire from the volar aspect and make sure that your reduction is good.
Just one technical point, as Binu mentioned. So yes, if you withdraw the K-wire so that you can extend the wrist to get images, you have to be careful when you pass the K-wire back out if you do it percutaneously, because you can incarcerate or impale a tendon, which I've done. And when you start drilling, you'll notice that you're winding up a tendon. That's not great. So I actually make a little incision when I do it dorsally. I don't necessarily expose the fracture, but I do expose the scaphoid, and I know exactly where the screw is entering, and I make sure that the trailing end is buried under the cartilage, which I think it's hard to assess by X-ray alone.
I agree. Yeah,
I agree with that.
Yeah.
Yeah, I have a question for Dr. Cassidy. Like you said, you go through the trapezium while you're drilling through so when you put the screw and like in a headless screw, like the screwdriver gives the counter when it goes and touches the scaphoid. But here the screwdriver would lie on the trapezium. So is the compression, I mean, do we achieve good compression in spite of the counter being on the trapezium and not on the scaphoid? for a headache?
Yeah, I guess it's right. That may be dependent on the type of screw that you're using. So I use a conical screw with variable pitch. So the driver is not pushing against the bone. But that's a great point. If you use a driver mechanism like that, you'd have to be against the bone itself.
I think some of these systems do come with a larger drill to drill the trapezium also.
Mm-hmm.
Can I just come in regarding the previous question, the one about how do we get a central screw in the proximal fragment? I think that's a very good question, because very often the fracture line may not be transverse. You could have a slightly awkward fracture configuration. So whereas going to the trapezium is fine to get your screw centrally into the distal part, when you reach the proximal part, very often it goes skew-whiff. You lose control of the proximal fragment. And I think that's where the arthroscopy bit comes in, because you could visualize this using one of those Acumet type wrist jacks, and use that with a C-arm to put a K-wire into the proximal fragment and jockey stick it, move it, and then put your wire through. It's a little bit complicated, but one of the more difficult hand operations, I think, is trying to fix a comminuted scaphoid fracture. When you have a lot of volar comminution, it's very hard to fix it percutaneously, anatomically. And then if you want a central configuration like Binu has said, you do really need to be able to visualize from the mid-carpal and radiocarpal joint. Obviously, not that easy and slightly theoretical when it comes to real-world issues, but it's quite a good question, and I think I've been caught out a few times with that problem.
It is quite likely with advanced 3D imaging that will be mobile and available in the operating room, all these problems will be obviated, because they are in the works. And in fact, Siemens already has a C-arm which does mobile 3D imaging in the operating room, which we saw in Davos year before last. And it'll come out in the mini version very soon. So we may not be discussing this question too much in the near future.
Yeah, I think it's been a great discussion. We need to move on. We are way off our time. So Jagan, if you can turn on the next video, it's going to be about Scaphoid Non-Unions. Thank you, Binu. We now look at Scaphoid Non-Unions. Why doesn't the scaphoid unite? We know it has a peculiar vascular supply. We know that more than 70% of this bone is intra-articular. It's predominantly cortical. It has very complex kinematics linking the proximal and the distal row of the carpus. And of course, we, in great measure, add to that problem. When you are faced with a patient with scaphoid non-union, clinically what you find is that there will be pain, there are restricted movements, sometimes there's swelling, and of course there's a weak grip. To examine the patient, you should be seated right across the patient, across a small narrow table, with the elbow of the patient rested and your elbow rested, so that you can actually palpate each of these points. As Binu did aver to this, that the classical point is the snuff box. But if you want to palpate the proximal pole, you need to palpate just distal to the Lister's tubercle and on the radial aspect. And if you get tenderness there, you know that the proximal pole is affected. And if it's the distal pole or the tuberosity that you're looking for, then run your finger across from the PC-form towards the radial side, and the bony prominence that you feel there is the scaphoid tuberosity. So if you get tenderness there, you can be sure that there is some pathology there. The multiple views that Binu spoke about, the 4 views, in addition to that, you might add a semi-supinated view and maybe a traction view to get a very good idea of what you're dealing with. The CT scan does help in planning, but when you're looking for avascularity, especially in non-unions, I think it's a bit subjective. So you have to turn to the MRI, so eloquently discussed by Binu, but sometimes you can have the entire scaphoid looking avascular, different from the rest of the carpal bones, but that's basically ischemia. So you need to actually find out whether it is avascular or ischemic. And for that, you must use a contrast and then see the enhancement. And if the enhancement is equal in the proximal and the distal poles, then you know that this proximal pole is being perfused, as opposed to the one in the next example, where you find that it isn't being enhanced despite gadolinium. And when you see this, if you can add time at which this enhancement is occurring, as seen in this graph, the proximal and the distal pole seem to be mimicking each other. The graphs are almost equal. That means the perfusion is at the same rate, as opposed to this one where it's completely flat. It's not taking any blood in. And this tells you this is definitely avascular. And these graphs can be seen as early as 4 to 6 weeks. But of course, the science on this is still in the evolving stage. So then we need to fall back on what David Green told us, and that is look at the proximal pole once you are doing your surgery and see whether it's lush or pink, whether there's punctate bleeding, whether it is chalky. What do we need to do? We need to restore biology, achieve compression, normalize the kinematics, and where needed, we need to restore vascularity. I like to also add one more dimension to this. And this paper from Wrightington talks about the fragment size and the time from the time of the injury to time of surgery. So if the fragment size is larger, you have a better chance of union. And if the fragment size is smaller, obviously it's going to be much more difficult when you're dealing with the proximal pole. And when you look at the fragment ratio from the left to the right, as it becomes larger, the chances of union go higher. The probability of union goes higher. If you see at a particular level, the patient at the first year following the injury, there's an 83% in this example chance of this patient uniting. The same patient, same level comes to you at 5 years, that probability has dropped to 56 or 57%. So time is extremely important. So fragment size and time, these are things that should also guide the treatment. Binu has shown us a case where after 60 days, he just put a compression screw because there wasn't any collapse. So you need to look and see whether it's a lax crepitant displaced or a collapsed non-union, and then think in terms of getting in a bone graft. So when you think in terms of bone graft, you need to also know what kind of graft are you going to use for which case. So if there is no collapse, which you can make out from the carpal height, you can make out from the size of the scaphoid as compared to the opposite side, or the intrascaphoid angle. If you find there's no collapse, then you might use just cancellous bones from the distal radius and give a good compression screw and get union. But what if there is collapse? Then you need to get structural bone in. So if it's in the waist or distal to that, you need to get structural bone either from the distal radius or from the iliac crest and do a procedure. Especially so when you're dealing with the humpback deformity. And the humpback deformity is one where there is you see overhanging bone on both sides, and it looks as though there's callus forming. Actually, it's the larger distal part that's hanging the narrower proximal part of the bone, which gives rise to that effect of illusion of callus being formed. But basically, it is volar flexion of the distal fragment with shortening, with a dorsal shift of the distal fragment and a DZ deformity. And these DZ deformities are more common when the injury lies distal to the dorsal intercarpal ligament as seen here. And why does that happen? That happens because of the repeated flexion and extension that can cause erosion of the bone and cause loss of bone. So when you have that kind of loss of bone, you need to replace that using a structural graft as seen here. A triangular wedge of the Fisk-Fernandez kind is being harvested from the iliac crest, put into the gap and fixed. So now how do you create the gap? Once you've cleared out the fracture side, the non-union side, you push in joy pins in the proximal, joy sticks in the proximal and distal fragments, pull them apart. And when you look at the defect that you create, when you pull the scaphoid back to its height, It should look like this on your image intensifier. This is before stretching it out. Look at the mid-carpal joint. It's all overlapped. At the moment you pull it apart, you restore the scaphoid height. Look at the smiley of the mid-carpal joint. So that tells you that the mid-carpal joint is happy to have the scaphoid back in its normal length, and therefore that is the gap that you need to fix. So you need to put in bone grafts to keep that position opened out, and then get that graft to be snug, snap fit, for which you need to tailor the graft, spread open the gap, and punch it down to the level. So on the left, you see tailoring of the graft while the two joysticks are held apart. And in this video, you see the punching of the graft, very gentle with a good punch. You also need to see to it that you get compression. So you need to choose your screw correctly. That means you need to use either short threads when you're dealing with more proximal fragments, or long threads. And whichever technique you use for the compression, you must understand the technique and use it to its best advantage. So here's that non-union that has united with a good function at 16 weeks. When there is established avascularity of the proximal pole, then you need to bring in some blood supply. So here's a case where it is an established non-union with avascularity. That's punctate bleeding that's seen. Zeidenberg graft was taken from the distal radius based on the 1-2 intercompartmental supraretinacular artery, and it was wedged in, and a screw was used to fix it down, which then went on to union at 17 weeks. Are these grafts infallible? When Zeidenberg first presented his work in 1991, there was 100% union. The same was reflected in the Mayo group in 2002. But as they studied these cases over a period of time, they found that in AVN, they saw only 50% unions, which means this wasn't bringing enough blood supply, or wasn't doing enough to get that bone to unite. And that fell further when they studied these over a long period of time. So what else can we do in these cases where it tends to fail? Here's one of my patients where I did a Zeidenberg graft. It looked okay at 5 months, not too great, but at 19 months, it definitely fell apart. So here is where we thought in terms of using the medial femoral condyle graft and fix it down. The place where I would indicate this is for patients who are willing, with an established avascular necrosis, or in failed attempts, earlier attempts, like in the case that we are discussing, or when the non-union of the proximal pole is over a long period of time. I wouldn't then try something that may not be as effective as the femoral condyle graft. So here's another patient. This graft requires a microvascular anastomosis of the artery and vein at the wrist. So you need to harvest this very carefully from the medial femoral condyle, non-articulating part. You can get the entire distal proximal pole reconstructed using this technique. You can fix it down if there's enough bone with screws, or you might choose to use wires. We did publish this. We've done over 20 cases now, and almost all of them have united. And the world literature shows upwards of 90% of these grafts that tend to unite. So we do have some answers when we're dealing with non-unions. We know that a younger patient is going to unite. We know that an earlier non-union can unite. We know that a patient who smokes doesn't unite. We know the kind of fractures that are more distal or affecting the waist are going to unite. We know that the oblique ones take longer to heal. And that if you're using K-wires versus screws with compression, chances are slightly more tilted in favor of using the screws. So finally, how would I look at a scaphoid non-union? When I look at a scaphoid non-union, what I need to understand is there collapse or is there avascularity? If there's neither of those, I would choose compression screws with cancellous grafts. If there was collapse, but no avascularity, then I would think in terms of using the Fernandez iliac crest graft. If there was no collapse, and if there was avascularity of the proximal pole, I would think in terms of using a distal radius vascularized graft. And if there was collapse and there was avascularity, I would then choose the medial femoral condyle graft. I thank you for your attention. So that's trying to simplify it a bit, oversimplify it, if I may say. It's much more difficult than that to make those decisions and to carry them through to get union. These proximal pole non-unions really are very, very tough to deal with. Anil and Rohan, are there any questions?
Nothing yet.
None. Any comments on on the talk from any of the panelists?
That was wonderfully summarized. The only difference I have probably from what you projected was proximal poles. I have pretty much abandoned vascularized bone grafts nearly 15 years ago. And I just recently published my own data, which mirrors Mark Cohen's data, where, nascent non-unions and established non-unions, you can get, I've been lucky to get them to heal with traditional techniques. But I agree with you in that, if it's failed once, then you may need to go much bigger in terms of technique.
When you talk about much bigger, I would like Sumedh to come in because they tend to plate the scaphoid.
Yeah, but you can't plate a proximal pole.
No.
No. So that's a different type of fracture. So I mean, the proximal, if you remember the talk that I gave, I'd said that as you move more proximally, one of the problems that occurs is that that plate produces impingement on the volar lip of the radius. And every time the person flexes, the proximal most screw tends to impinge. So you get you get rid of one pain problem and you create another one. So it's not ideal for that. I just wanted to ask you another question, Sudhir. So our entire series, we looked at Zeidenberg, we looked at vascular, and it was like a toss of a coin. It was 50% chance. So we weren't able to replicate Zeidenberg's work. Like Chaitanya, we found that it just doesn't work in our hands. Clearly, there are people who can make it work, but as an institution, we haven't been able to do it. So it doesn't work. So when you have, as a tertiary surgeon, when you have a referral, say you have someone who's 28 or 30, who is active, they do the dips, as you call them. They're very fit and healthy, but someone does an X-ray for some reason and they find a scaphoid fracture, and it comes to you, and they come to you saying, I've been told I'll get arthritis, I want this fixed. So, I mean, how do you approach that sort of problem? Because clearly this person is physically fit. The only thing I'm sure of now is that I'm going to give him a scar, one, and two, if it's a very old non-union, I know in my mind that it's not going to heal. So I mean, I'm sorry to put you in an awkward position because I haven't found an answer for that. So it's just a question of discussion point.
This is an interesting thing because this is what happens, and you're sitting like you mentioned at the tertiary center where you seem to you should be knowing the answers to almost all the problems, and there is no place that you can send this patient to for for better advice. And as you mentioned that you do have experiences that are not very encouraging sometimes. So the way I would approach this is, of course, to first discuss with the patient that he is doing dips, as you mentioned. So I would tell him that most of these changes of arthritis, if they haven't started early, which means if it's not maybe a proximal pole non-union or a fracture that is already articulating with the radial styloid, then probably the symptoms are going to arise in the second or third decade after the fracture has happened, and which is quite commonly what we see. So I would warn this patient that he's headed in that direction. There aren't any signs. So this is the period what Dr. Tarapurwala would call the asymptomatic non-union of the scaphoid, which eventually may become symptomatic. But then offering such a patient a procedure that you're not 100% sure of is very, very dicey. So in such cases where I'm sure of, where it's a proximal pole, I would try and convince him to get the medial femoral condyle graft done. In our hands, of course, like I mentioned, more than 20 cases. I think we have done 21 cases. And the reason I fumbled about all of them uniting was the last one was done in January this year, and during the lockdown, and he's done well as well. So he's also united now. And those are the ones I think I'm more confident of. So if I'm in a tight spot, that's what I would offer for the proximal pole. The Fisk-Fernandez grafts, most of them would unite. The ones in the waist, most of them would unite. So the ones without vascularity are the ones that are very, very difficult to predict. Anyone else with any opinions on this?
Dr. Warrier, there's a question from the audience.
Yeah.
Dr. Bipin asks, what is the exact demarcation for a proximal pole anatomically? Are there any?
That's exactly the reason I put up that slide from Wrightington. There is no mark on the scaphoid or a level on the scaphoid which tells you from here on, sorry, there's no blood supply. That fragment ratio is it illuminates exactly this point, that as you come down from the distal pole towards that percentage of union keeps on becoming smaller and smaller and smaller. So there is definitely no specific line as such. So as it comes, it's a question of the amount of time, it's a question of the amount of the fragment, and it's a question of the amount of sclerosis there is. And then when you open up, you also look at what David Green said. So if it's chalky and marble-like, you know you're dealing with a very difficult one. But if you find punctate bleeding, or if you see it nice and pink and lush and it bleeds, when you're pouring it out, then you know you're on a much better wicket.
The official position is that if it doesn't heal, it was a proximal pole fracture. That's the official.
Yeah, that's always a good recourse.
Jokes aside, this same question came up for discussion when we were writing our paper, and we scanned the data and the literature, and there's no consistent definition of what constitutes a proximal pole. So we used an arbitrary line. If the entirety of the fracture line was proximal to the head of the capitate, we call that a proximal pole. I don't know if that's right or wrong, but that's the definition we used.
That's a good thumb rule, a clinical thumb rule to use in your practice. That's fantastic.
What about a rule of thirds?
A rule of thirds.
I think
Sudhir,
it's very helpful to,
I have.
very helpful to look at CTs, CTs with especially if you can get 3D reconstructions, because the fractures may be very oblique and it may look like a waist fracture on the volar side, but proximal on the dorsal side. And to me, if it's proximal to the dorsal ridge on the 3D, you could really see the dorsal ridge. Then I worry it's more considered a proximal pole.
Dr. Warrior, a little about the vascularity. I mean, I think Ruby has done a lot of work on that. I mean, AVN is basically a spectrum. I mean, it starts from the ischemia to necrosis and infarction, and we know the so much of ambiguity in terms of MRIs, unenhanced or enhanced, or even the dynamic ones. So, what is the answer in terms of the vascularity itself at the end of the day?
Ruby, would you like to?
I think that at the end of the day, we don't really know. If we look at what the literature shows us, even absence of punctate bleeding, if they take histological specimens, pathologically, they were not able to show necrosis. But for me, I think of it more of a clinical. If I'm looking at the bone and it doesn't look vascular to me, if I don't see punctate bleeding with the tourniquet down, then I think regardless of what the histology tells us, you basically know intuitively you're going to have problems with union. I'm more in Sudhir's camp with vascularized grafting. I think that biologically it makes sense. If we're going to put in a graft, one with its own blood supply should do better compared to one that doesn't have its own blood supply. So I'm kind of trending towards offering it to patients at the first go, because I think that the first surgery we do is going to give them their best chance of success, compared to doing it, waiting for it to fail, and then trying to do a vascularized graft. So something that has very low morbidity, like a distal radius pedicled graft, whether you use one like Methuen described from the volar carpal artery or the Zeidenberg. In my hands, I do find that that does well. We did a little trial looking at that, and whether there was an advantage or not, I don't think we had the numbers to show that, but we certainly did show that there's no disadvantage. You know, we didn't have any increase in stiffness or complications, et cetera. So I think maybe we should, I think this is an unanswered question as of yet. And part of it is because we don't know how to define vascularity. We don't know how to define proximal pole, and we need to have some consistency in that before we can really interpret the literature.
Has any of the faculty changed the what you do after seeing the vascularity of the proximal pole? Like in between the surgery, you are planning for a non-vascularized graft and you don't see punctate bleeding, then will you go for a vascularized bone graft, or does it make any difference? That's what I'm asking.
Not to me.
I've gone the other way. Sorry, I've gone the other way once. I go in trying to do a vascularized graft, don't find a good enough pedicle, or maybe I just messed it up. And then I had to take recourse to the non-vascularized, and quite surprisingly, that patient did very well.
Aha.
I think the cartilage status probably is the more deciding factor. I mean, when you look at the cartilage of both the scaphoid and the radial side, I think that's when things might change. The plan might change much faster than just the quality of the bone itself. So how thinned out the whole process started, because it might not be a frank, snack wrist or whatever, but when you open up and you see the cartilage, it started with grade 1 or 2, and then you probably change your plan.
Okay. And one more question. What is the choice of implant, Sudhir, when you have a proximal pole vascularity?
Yeah, that's the big worry, that once you bring in a vascularized graft, then you worry that your drill and your wires are going to just destroy all your work that you've done up until then. So that's one really big worry. And we've tended to use K wires more often and more quickly than if we have any doubt about the size of the proximal pole and whether it's been cored out to the shell, then there's no point putting in a screw, or it's difficult to put in a screw. So then I would choose multiple K wires. The other thing is, when you bring in the medial femoral condyle graft, you come in with such a large chunk of bone that you want all of it to be there because it looks so nice. And by the time you trim it down and trim it down and trim it down, it looks so tiny. And then you start wondering how you're going to get it in there, and how big a trough can you make, and then how are you going to fix it down. So these are definitely some of the more difficult problems with scaphoid avascularity and scaphoid non-union.
I would just like to make a point about K-wires. I think we always talk about compression screws, but for the non-union that has a lot of collapse, compression may not be helpful here, because you can compress your proximal pole, you can cause it to fragment. K-wires may not be fancy, or you may not great compression, but you will consistently get a good result. You may have to, it may take a little bit longer for it to unite, but I think if you're somebody that doesn't do this often, it's a fail-safe technique, and I certainly would recommend it.
I would second that, and I also, when you're especially dealing with a proximal pole, I would add a scaphocapitate wire temporarily. That will hold it up and add much more stability to the construct.
Sudhir, the basic science data also shows that after you put in a compression screw, quote unquote compression, within the first 24 hours, anywhere up to 12 to 20% of compression is lost, depending on what screw design you use. So, we can fool ourselves into thinking we have that compression, but is it really? And Jesse used to make a good point. Is it stability, or is it biology? Or is it a judicious combination of both?
Yeah, and I can't leave a discussion on scaphoids without taking the name of Dr. Hemant Patankar, whose work I'm sure is going to be published soon. But he did use only K wires, and he's got some of the most amazing results with scaphoid non-unions, including proximal poles using only K wires. And simple grafts, no vascularized grafts either. Yeah, Rohan, quickly.
Yeah, just a yes and no question. While you're doing a non-union scaphoid, during surgery, do you release a tourniquet to assess the vascularity of the proximal pole?
Ruby said she did. If you're really Can you say that again, please?
I don't routinely release the tourniquet. If I have any doubt about it, I will go to a vascularized graft, because in my hands, I don't find that there's a higher complication risk, and I can use a local pedicle. So I have a very low threshold for doing a vascular.
If I can't get it out with a gouge or a small scoop, a curette, and if I'm going to be using a burr, a micro burr, and I'm seeing cortical bone like ivory coming out, then maybe I would be tempted to take down the tourniquet, take a look, reconsider my steps, and then go back in.
I think if the bone is vascular, even in a tourniquet, you would see that bleeding, which happens like a delayed kind of, it fills up nicely after you do the burring and everything. So if it doesn't absolutely looks chalky, I think even with the release of tourniquet, nothing might improve actually.
I agree. I don't let the tourniquet down. Just one point about compression screws. I think it's really important. These screws that are fully threaded, differential pitch or terminally threaded in the leading end with a smooth shaft, they're not really compression screws. They're like a gear, and they'll translate the bones together a little bit, but not that much, right? So if there's a significant gap, it won't necessarily compress it to the point where it's opposed. So these techniques do require apposition of the fracture. Even if you're doing it percutaneously, if it's gapped, most of those drivers will not compress the bone so that it's actually touching. Very important point. It's not like the traditional interfragmentary screw that we would use with a head.
We've actually been using as a positional screw, you know. So we do the screw first and then the graft. Actually, we do the cancellous compact graft. Actually, make it. I mean, use the screw more of a positional screw. Get the length and then pack in the graft. That's what we do. We just send it for publication. So we do that technique.
That's what we call an expensive K-wire.
Is anyone a proponent of 2 screws to get some rotational control?
I have a hard enough time getting 1 screw in.
Yeah, and we do.
In Indian wrists, I don't think we have enough space for that.
There's 2 points. There's 2 points about the Indian wrists. One is you can't get in 2 screws, and number 2, you don't get smaller size screws.
You don't get smaller size screws also.
3.1, mainly the ones that we're using are 3.1 or above. So
there's a third point. There's a third point, Sudhir. Mm-hmm. If you put in 2 screws, you don't have to worry about union because there are no trabecular left to unite. I mean, come on.
Right, let's move on. And I'd like to introduce Becky Nidesky, who's the Dean from the School of Health Sciences at Elon University, North Carolina. And she has educated a large number of hand therapists across many countries. And when she gets time away from the hand therapy unit, she's a super baker, and her favorite is the peanut butter oatmeal chocolate chip, which someday we all would love to taste. Becky.
My name is Becky Nidesky, and I'm coming to you from Elon University in North Carolina in the United States. My first talk for this evening is rehabilitation following scaphoid fractures. 90% of scaphoid fractures occur from a force applied with the wrist and extension. The scaphoid is especially vulnerable to injury as it spans both the proximal and distal rows and blocks extreme wrist extension. The scaphoid fracture is often difficult to diagnose and is often made based on clinical signs such as pain in the snuff box. And there are variable healing times according to fracture site. Diagnosis of a scaphoid fracture is difficult and oftentimes missed. And so it's important for your therapist to know what the clinical signs are that you are looking for in terms of scaphoid fracture diagnosis, so they could refer the patient back to you if they fear that there's a scaphoid fracture that has not been diagnosed. So let's look at those healing times. The distal 2/3 of the scaphoid typically takes 10 to 12 weeks to heal, whereas the proximal third can take up 12 or more weeks to heal. What are the reasons for these healing times? We know that there's a poor vascular supply to the proximal third. The direction of the fracture can affect healing, and that the blood supply enters distally, which can lead to avascular necrosis of the proximal pole. Again, all these anatomical variables and the healing time are important concepts to share with the therapist working with the patients. So how do we treat the patient after a scaphoid fracture? If there's been surgical intervention, we typically will immobilize for between 4 and 16 weeks in a cast or orthosis with the IP free until there's bony union. Conservatively, therapists can make a thumb spica cast or a splint with the IP free. The wrist will be in slight extension and radial deviation, like the splint shown on the right. Again, it's important for your patients to understand why they're being immobilized for so long, so that educational factor around the healing times and the proximal versus distal pole of the scaphoid fracture is an essential part of the education that your therapist can help provide. So then what will a therapist do with the patient after scaphoid fracture? Certainly in the early phases, even between that first and 16 weeks, it might be really helpful for the patient to see a therapist to help with edema management, splinting for stability and protection, and pain management. Therapists are really good at monitoring increased sympathetic reactions and also using modalities to help manage pain. Motion and function preceded by the therapist will be based on the healing status, and certainly that's going to require a high level of communication between surgeon and therapist. Mobilization, typically your therapist will focus on both wrist and thumb range of motion and composite flexion. Oftentimes the patient may require protective splinting between exercise and after the cast or splint removal. And we encourage early functional activities of daily living. And so when the patient is ready and the scaphoid has been deemed as healed or healing and safe to actually begin moving forward, we want to help the patient really carefully return to their activities of daily living and grade the activities they do on a daily basis. And finally, we want to help the patients return to function. If we need to, a therapist can create a static progressive or a dynamic splint for either wrist flexion or extension or composite motion. And so we do have some advanced tools in our toolkit to help return motion for the patient. We can help the patient work on grip strengthening, wrist strengthening within a pain-free range. And in the United States, we use work hardening depending on return to work status to help those patients with high level jobs in terms of required strength and required stability. We can help them do work hardening and return to their actual work tasks. And with that, I thank you very much.
Thank you, Becky. That was fantastic. One of the problems that many of our surgeons face is that we do not have trained hand therapists. And generally, I mean, the progression sometimes is a little abrupt or sometimes is very, very slow. As time goes by, you start losing the opportunity of restoring movements. You lose the best time when you can actually bring back that and the balance in the different muscles. And the other problem being that we do not have good splints being fabricated for them. So some of us, of course, are very fortunate that we have created that or have that available to us, but that's not the common thing that's seen across India.
I think there's an interesting opportunity as I was listening to the first two talks to think about even during casting, right? So if the patient, if you are able to leave the IP free, if you're feeling like that's a safe choice, if you're able to make sure that there's full MP flexion when the patients are immobilized, if you're able to give them a little bit of education about elbow and shoulder motion, you're going to offset a lot of the extra problems, right? So that the patient is going to then be left just having to rehab the wrist and potentially the CMC joint and the MP joint of the thumb. And I think that education in the very early phase, that motion of the joints that are not protected is incredibly important and will lead to better function at the end of treatment. So I think even if there's not a therapist present, I think that 5 minutes of, and I call it permission, giving the patient permission to move those joints that are not immobilized by the cast you create and making sure the casts allow motion of the joints that don't need to be mobilized will make a significant difference in the long run.
Even if it's been drilled into our mind that, from our PG day, postgraduate days, that you have to put a thumb spica cast for a scaphoid fracture. Nowadays, literature is definitely showing that you can leave the thumb free and have the same amount of union. So I think we can be a little less radical in casting.
Yeah, we still face questions from some of the students who say one joint above and one joint below need to be immobilized, and you have no answer to that. But of course, there's enough literature to show that that it doesn't really matter too much. Are there any questions, Anil? No.
Yeah, Dr.
Yes,
Warrior.
Rohan. Yes, Rohan.
Is the question is, I think, in general to all the faculty, what are the faculty's preferred rehabilitation protocols after surgery? Is it a cast? Is it a splint? And for how long?
That seems kind of generic. So
this is for the scaphoid fracture surgery. So let's put it as an acute scaphoid fracture surgery. If you have, say, put in a percutaneous screw, then would your choice be a cast or a splint?
For me, it depends on whether it's a waist or a proximal pole. If it's a waist, I would cast them for a couple weeks for comfort, and then place them in a splint and start rehab. If it's a proximal pole, I would fix them and cast them for 6 weeks, because I just don't trust proximal poles.
Part of the decision is occupation related, I would say. So for example, physicians and nurses can't work if they have a cast on. So those people I would put in a splint. And my algorithm is, if I can't see the fracture and I do it percutaneously, I just use a splint. You know, when they come back, I get a post-op x-ray, and if it looks great, I just put them in a splint.
I cast for 3 weeks first for Wyss fractures, even if I use a screw, and then change it into a splint and start gentle mobilization. But for KYS, 6 weeks plus an additional 4 weeks, I'll cast.
Yeah, I generally keep a cast on for 6 weeks. I had a surgeon who didn't have access to a therapist, and 2 weeks or 3 weeks from the time of surgery, he put his hand in the chair between the seat and the backrest, and he tried to do his exercises, and he got a video of him trying to get his wrist to move. Ever since then, I've been a little more careful. I tend to give a cast for about 5 to 6 weeks. I don't see too much of stiffness, either acutely or even in the non-union. But as Chuck mentioned, that if the profession demands that they get back movements, I may be a little easy on that and leave it at 3 weeks or so. But yes, I would leave a cast on for at least 3 weeks.
Sudhir, did the fracture heal in that position?
It did. It did.
Well, maybe we're over treating our patients.
Maybe I was good with the fixation.
That's right. Well, we know you are. I have a question for Becky, maybe an obvious one, but is there a particular range of motion deficit that patients particularly find disabling? What do you think is the most?
It's a good question. And if you think about the total range of motion, especially of flexion and extension, you know that that's typically from 70 degrees of flexion to about 80 degrees of extension. But we also know there's good literature to support that the mid-range between 40 and 40 is truly functional. The hardest part, in my opinion, is the visual, that the patient can actually say, hey, look, I have less flexion here than I have here. And so I think there's a psychological aspect to wanting as much motion as we have in the other hand, even though we may not need it functionally. In my opinion, I think loss of extension is difficult, obviously functionally, but definitely the pronation and supination piece that I think we often overlook when we immobilize the wrist. If we're not getting some functional pronation and supination, I think people really struggle, especially when they can't bring that forearm into rotation to actually approximate to do their functional tasks. But Dr. Cassidy, I think it's a good question, because I think that people misunderstand the visual of motion as a loss of function.
Dr. Warrior?
Yep.
Yeah, I mean, the cast always we tell leave the IP free and everything, but then when we put the splint, generally if the splint's available at least here would be a thumb spiker splint, again going all the way up to the tip of the thumb. Becky, is there any specific splint you would recommend, or is it like, because in India generally the ready-made splints are the thumb spiker splints where it goes all the way till the IP joint?
I think that's also a great question. And I think to the previous point, the question around conservative management with a thumb spica versus a wrist resting or a wrist cock-up splint is a worthy conversation. Your therapist certainly would love to have that patient be moving their thumb and be able to be a little bit more functional if you deem that safe. But the other thing I would really encourage is if the IP joint does not need to be immobilized, whatever tool you have to cut that IP joint out of that splint would inherently incredibly help your patient to not only glide the tendons, but also then hopefully kind of decrease the amount of issues you have to deal with in the long term. Even the IP free, if the thumb is positioned in good palmar abduction, your patient can get some nice functional use depending on the position. But that's where thumb splints are interesting, right? Because if the thumb is coming off the palmar plane, you're going to be more functional. But if those are those ugly splints with the thumb off, kind of in more of that radial abduction, this is not functional for your patient at all. And you're preserving the web space, but not doing them a whole lot more good. And so I would say if you're going to go to a thumb spica, make sure the thumb is kind of in that palmarly abducted plane and decreasing the IP kind of immobilization, if at all possible.
I think we need to get moving. It's my pleasure to introduce Chuck Cassidy from the Tufts Medical Center in Boston, with whom Chai and I have had the privilege of being co-faculty at the DeVos Master's course twice. He, among many other awards, has won the Mentor of the Year award at his hospital, and also is a repeated top doctor award winner in USA. And I did see one reference which said he was amongst the top 1%. I would like to know how they calculate that and where I stand in my country. Chuck, he's going to speak about Kienbock's disease.
Hi, my name is Chuck Cassidy from Tufts Medical Center in Boston, Massachusetts. First, I'd like to thank my friends Chai and Sudhir for the privilege of being able to speak with you today. Since 1910, up until this very day in 2021, where we have a helicopter on Mars, Kienbock's has been an enigma. It's really still a black box for us. For example, what is the etiology? If it's a vascular problem, why don't these patients with lunate dislocations develop Kienbock's? Or if it's a shearing problem, why don't these patients with distal ulnar resection develop Kienbock's? Furthermore, is ulnar variance a factor? Some say yes, some say no. Lunate shape? Perhaps the trapezoidal shape does predispose to Kienbock's? Or how about this? A mother age 63 and a daughter age 35, both with Kienbock, both totally healthy. In fact, the daughter's condition is more advanced than the mother's. There are a myriad of treatments for Kienbock's these days, including anti-inflammatory medications, direct revascularization, for example, the Saterianos capsular flap, or the 4-5 extracompartmental supraretinacular artery, or a joint leveling procedure such as a radial shortening, or unloading procedures including capitate shortening, STT arthrodesis, closing or opening radial wedge osteotomies. Incredibly, all with about 72% success. And that's the theme for this morning. There are a myriad of treatments for Kienbock's, including this medial femoral vascularized condylar osteochondral graft, which is an ambitious operation, with only preliminary results, which appear to be about 72%. In fact, the patients tend to lose some motion compared with how they were preoperatively. Or how about this operation, an osteotomy of the radius without shortening, so just cutting the bone for Kienbock disease, a 10-year follow-up. Patients with a spectrum of stages of Kienbock's with a result of 72%. What about cord decompression? It was very popular in the hip a while back and has been supplanted by total hip arthroplasty, of course. The results there, 72%. Cord decompression directly of the lunate has been described in a couple of papers, including this one from Bain, using an arthroscopically assisted approach, Another paper from 2011 demonstrated a VAS score improvement from 88 to 14, which is about a 72% improvement. The original paper on cord decompression was not actually of the lunate itself, but of the radius and ulna in 2001 from Buenos Aires. And as you see here, 16 of 22% pain-free at 10-year follow-up, or about 72%. In this systematic review of treatment of Kienbock's disease in its early and late stages, bone grafting, cord decompression, and osteotomy were equivalent. In fact, maybe the pain relief, which is in light blue, was a little bit better with cord decompression than the other operations. 72% again. In this paper from 2017, using a radius cord decompression for Kienbock disease for stage 3A with 13 years follow-up, here again we see about a 72% improvement. And interestingly, these patients had bone scans preoperatively and postoperatively, and you can see the uptake in the lunate preoperatively, and then the area of increased vascularity to not only the radius, but the carpus itself 5 months postoperatively, suggesting that there is some local vascular enhancement following that simple operation. Is there any role for arthroscopy? Bain, in 2006, published a paper including a classification, arthroscopic that is, on Kienbock disease. On the left is a patient of mine who has softening of the lunate with an intact cartilage cap, and on the right, you can see a loose fragment of dead bone on the ulnar aspect of the lunate. And so here, for example, is that patient where you can see there's a fracture, there's collapse of the lunate, of course, and dysvascular findings on MR, but with that fragment in the ulnar aspect of the lunate. And that, for me, may be an indication for arthroscopy. Is there any role for denervation? This paper from 2011 included complete denervation in 49 patients, including 13 with Kienbock disease, and noted 79% pain relief, close to 72%. That's a highly morbid operation. There may be a better alternative, and that is simple posterior and anterior interosseous neurectomy through a dorsal exposure proximal to the distal radial joint. A 1 centimeter segment of the posterior interosseous nerve is resected. A window is made in the interosseous membrane, and then a 1 centimeter segment of the anterior interosseous nerve, ideally after the pronator quadratus branches, is resected. And at the same time, for me, it's little big deal to place a drill and do a little metaphyseal decompression through the same small incision. So my algorithm in managing Kienbock disease these days is a diagnostic PIN and AIN anesthetic injection in the office. If patients obtain good pain relief, then a neurectomy of the PIN and AIN and metaphyseal drilling is indicated. And then I may elect to perform arthroscopy if there are mechanical symptoms or an obvious loose body. If there's no relief from the injection and the lunate is intact without arthritis, then I will do a joint leveling procedure if the radiographs demonstrate ulnar minus, or a vascularized graft into the lunate if they're ulnar neutral or positive. If there's lunate collapse in arthritis, a proximal oral carpectomy for me is the answer. It is important to remember that bone graft alone does not restore cartilage. So in this example, a patient with stage 4, you can see the collapse and fragmentation of the lunate with some changes in the radiolunate articular surface. To me, that's not necessarily a contraindication to a proximal oral carpectomy. In that instance, I will include an interposition. And so here is that patient. You can see this is an intraoperative photo looking from proximal to distal at the scaphoid on the left and the lunate on the right, with a fracture line within the lunate itself. This is the head of the capitate after
a proximal row carpectomy is performed, and you can see areas of full thickness cartilage loss in the head of the capitate. In this instance, we used a dermal allograft, and it is key to place all of the sutures into the volar capsule before tying any of them. And then once that is performed, it could be single ply, double ply, or triple ply. And then once those are secured, and then drape it over the capitate and the hamate, and then secure it to the area of the dorsal capsule. And here you can see on the right, the capitate and hamate are covered completely, and that is the X-ray on the left. So in summary for me, it is keep it simple, that these patients won't necessarily have a normal wrist, but the natural history is often that the pain does subside regardless of the treatment. And remember the 72%, and try to keep the scalpel away from the knee. Thank you.
Wonderful roundup, and quite interesting that dermal allograft and the way you get it to drape right from the volar capsule. That's a very, very interesting technique. Are there any questions? And to the participants, you can scroll down below your video. There is a Slido link, and you can send in your questions as you have them, so that we can address them where it's relevant.
I know that Chai has a variation of the technique using a capsular flap. Maybe Chai, you'd like to just describe what you do.
Sure. You know, for all my Kienbocks, when I know that I'm going to be doing a PRC, or anytime I'm approaching the dorsal aspect of the wrist with the idea of doing a salvage procedure, incision is standard, but the capsulotomy is always C-shaped, and it is based proximally, and it goes radially up to the first compartment, distally up to the CMC joints, and ulnarly to the DRUJ. And I raise that as a flap, then do my business on the inside. If I don't need to put the interposition, that's easy. I just sew it back normally. But if I have to sew it inside, you do your PRC and then just drop it in. Pre-place 3 sutures in your volar capsule. Don't tie them initially, because if you tie one, you can't place the other 2. Pre-place the 3 and then tie them sequentially while someone holds your wrist gently distracted. And then just let the capitate nestle back into the radius. I used to do it I used to do it the other way with the capsule based distally, but I found that the patients were losing flexion. So we just sent our results for publication. So.
Chuck, have you tried the Grainer's procedure where you osteotomize the capitate and put a bone graft?
I have not. I don't like to touch the capitate if I can help it. I think that's the driver if if you have a lunate problem. So I capitate shortening, I don't do it, and I don't touch the capitate. What can you describe what you do?
So you osteotomize the capitate and then put a iliac bone graft. So wherever the Kienbock, the lunate has been removed, the capitate comes in that place.
Oh, I see.
So,
effective
lengthening.
It's
leaving the rest
you're
of the proximal
lengthening, keeping the proximal row instead of taking out the proximal row.
Right. That's clever.
I mean, I have no personal experience with it, but I've seen it in the Journal of Hand Surgery. So I just asked whether any of the faculty has some experience with such procedure.
Wouldn't there be a concern for dysvascularity of the proximal pole of the capitate once you detach it and move it so much?
That's what the few reports on that, they said that they didn't have that problem.
Oh, okay. That's good to know.
So what's the role of Rohan? Please go ahead.
There's a question from the audience. Dr. Bipin wanted to know if it's a young male with a grade 3B Kienbock's disease where the lunate has collapsed. Is there a role for PRC or something else?
Yeah, that is a tough problem. I do admit, and maybe Sudhir has some experience using vascularized medial femoral condyle graft for lunate. I know Higgins does in the United States. I would consider a proximal row corpectomy. Well, first I would say it doesn't make any sense to bone graft it, right? If it's collapsed especially if the cartilage is no good. So maybe if you can inject some helium and re-expand the lunate somehow, you could have some success, but it's too far gone at that point. So you could do an arthrodesis, limited arthrodesis, or a PRC, or a vascularized osteochondral graft.
Yeah,
So do you have any experience?
We've seen such beautiful diagrams in books about and articles about bringing back the lunate to its size with distraction and putting in grafts and stuff like that. But I have never been able to do that. And every time I look at something that's collapsed like that, the cartilage definitely doesn't look healthy enough for me to be confident that it's going to do something good. And on the other side, you see the results of PRC and 4 corner fusions. They seem to last for long with few problems. Yes, of course, not the original ones, not the original problem, but they seem to do fairly well. And to your remark about the medial femoral condyle for lunate, I've seen one fail, which was done in one of the most prolific centers abroad. And I don't have the courage to try and do that for a completely collapsed one. Probably do a vascularized extensor compartment 4-5 vascularized graft for the early ones, but really not for one that's completely collapsed. Because like I said, the cartilage, I'm not confident that the cartilage will be able to withstand or reform and be healthy enough to give us good service.
Sudhir and Chuck, you have to divide the lunates into whether they are lunates that will survive or lunates that are, non-salvageable, right? If it's fragmented, you can put holy water in it. It's never going to survive. But if it's non-fragmented, then all the procedures we talked about may have a hope. Think about the femoral head. If it's fragmented, we jump to a total hip arthroplasty. So why do we think that we can get a fragmented lunate to come back to life, so to speak, right? And
I agree. I am much more nihilistic, and unfortunately I couldn't find the X-rays of a patient I saw a couple of weeks ago who I had done radial shortenings on. Probably I would say about 15 years ago, and she's I think 40 now, and her lunates are totally collapsed, and she's fine. She came in for a different problem. Her X-rays look awful, but she has no pain. She's a little stiff, which is it's not uncommon to have patients like that. For some reason, the pain may burn out, although the X-rays look lousy.
Yeah,
I think that's an important point. And so for that question about the 3B in a young patient, there have been case series reported where doing even something like a simple radial shortening osteotomy in those patients can be helpful. And I really like your presentation, Chuck, because I don't think we understand this problem. I don't think we understand the natural history. We don't know why it hurts for some people, and other people it's just an incidental finding. But I think there is an element of if you do anything, they seem to get better. And I will offer those patients something like a radial shortening. The thing I like about it is it doesn't burn any bridges. I do sell it in the way of this might be enough. It might not, and we might need to do a second operation. And most patients are on board because they want to preserve their function. They want to preserve their range. And I have very, very few that I've actually had to go back and do something else for. They seem to be happy with the pain relief that they get, and it seems to last.
Agreed. I'm sorry, there was one question on implant arthroplasty, and it really calls into question the issue about the linkage in the proximal row. And maybe Sudhir can comment on this, using osteochondral grafts. And for example, the proximal pole of the scaphoid, is there a scapholunate dissociation? If you take the lunate out, you've lost the linkage completely in the proximal row. And that for me is the principal problem with lunate implants. I've seen some that patients have come to the office with what they think is a ganglion, and it's their lunate implant that's dislocated, or it's in the carpal tunnel. It's crazy. There are crazy things that occur with those implants. So I personally don't use them.
We have done a complete replacement of the proximal pole with the femoral condyle with the articular cartilage, and probably what works is because we overstuff it. So they are a bit stiffer, but they seem to do fairly well as far as the pain is concerned. And of course, the follow-ups are very, very short. But yes, maybe something like that is probably what may be promising in this situation.
You know, Sudhir and Chuck, tell me what you guys think about this. Is it possible that we're looking at Kienbock's a little differently than we should be? We've always been talking about mechanics of it, but we really don't talk about the biology in that sense. You know, Gelberman defined those 3 variations of blood supply to the lunate, you know, X pattern, I pattern, and Y pattern. And then you also have data from Legg-Cave-Perthes disease, which showed that there's hypercoagulable states which lead to dysvascularity of the femoral head. So along the same lines, we did an unpublished study, which I did many years ago, where we found that protein C, protein S, antithrombin 3, and TPA levels were completely different in patients with Kienbock's. So is it possible that's a representation of a coagulopathic state in a lunate which already has tenuous vascularity? Just something to think about.
But why only the lunate, Chai?
Because it had, if it has that I pattern, as Gelberman described, if it's a single blood vessel going through the intraosseous portion, is it possible it's a lunate at risk? And which is why if they're coagulopathic, they end up...
We have a set of, a lot of patients come from Kerala with Perthes disease. And we get a lot of patients of Kienbock's from the same place.
Yeah.
And Dr. Benjamin Joseph did a lot of studies on IgM and other things for the Perthes disease patients. Of course, we didn't really do this for the Kienbock's patients. But they didn't find anything with the Perthes as such, the hypercoagulable state which you're talking of. But we get a majority of the patients from the same region, actually. Perthes and Kienbock's, both of them.
That's interesting. Yes.
Yeah, not Kerala, especially, Dr. Warrior. We get a lot of patients.
And you also do see a lot of idiopathic chondrolysis, if I mistake not, from exactly the same belt.
Yeah.
Interesting.
Something
in the it would be interesting to survey surgeons as to what they would do or have done for them if they, or their family member if they had this condition, right? So like I'm ambivalent because I like doing big operations. On the other hand, I wouldn't want that done to me for this problem. Don't touch my knee.
I have a friend who had Kienbock. He's a surgeon, spine surgeon. And 15 years back, I suggested that he get the revascularization done. He was probably Wyss, and he said no. He started operating with a splint. He sterilizes the splint and wore it on his wrist and were operating. Now, 15 years later, he's still fine. He has no complaints now. So that's the one way.
Yeah,
that's probably shooting ourselves on the foot as surgeons.
Yeah.
Right. Let's go ahead. And it's my pleasant duty now to introduce Ruby Grewal, who's the Associate Professor at the University of Western Ontario, Canada. And believe it or not, she has a master's degree in biostatistics and epidemiology. When she's not busy with all of that, she loves to play soccer and plays on the women's team there and enjoys swimming. And again, believe it or not, worked as a lifeguard. Ruby is going to speak about scapholunate injuries.
Hello, thank you very much for the invitation. I will be speaking about scapholunate injuries, and what I think is important is when you need to decide to go after these and fix them versus when you think that the patient's more appropriate for a salvage procedure. The decision to salvage is easy when you already have degenerative change, but sometimes that can be a little more difficult. And when you should repair or give up, I think is the most important thing clinically. As surgeons, we can all execute a technique once we've understood the nuances of the technical details, but that decision-making on which patients to choose, I think is the most important and what I'd like to focus on today. I love this quote by Lindau. Wrist problems in general and carpal instability in particular are diagnosed in 3/4 of the cases by history and physical examination. And that I think is is certainly true for scapholunate. I look for the perfect history. I want to know where their pain is and make sure it's in the right spot. I want to understand that their symptoms are actually correlated with the scapholunate instability. I will look to see that their point of tenderness is dorsal, just distal to Lister's tubercle in the region of the scapholunate. That is where the scaphoid will be subluxating dorsally, and I think those patients we can help the most. I will do the scaphoid shift test. I place a lot of importance on this. When you execute this maneuver and the patient tells you, yes, that is the problem, that pain and that clunking is what bugs me, I know these patients will do well. So just to remind ourselves what happens with the scaphoid shift, when the wrist is ulnarly deviated, the scaphoid is extended. When it flexes, the proximal pole, the scaphoid flexes and the proximal pole will subluxate dorsally as you're putting pressure on the scaphoid tubercle. When you remove your thumb, it will clunk back into place. And that is what is causing the pain, and that is considered a positive test. Always compare it to the other side, as some people will have instability without being symptomatic. Imaging, first step would be X-ray. You will see either a gap or an increased scapholunate angle. Always compare it to the other side. If you're unsure, get a dynamic grip view, and that can certainly bring out the scapholunate diastasis. I think a 3 millimeter gap or more is pathologic, but always in the context of what's normal for that patient by comparing their contralateral side. Look for that cortical ring sign. That's a sign that the scaphoid is flexed and you're seeing the distal pole superimposed. On the lateral, look for an increased scapholunate angle. Greater than 60 is pathologic. The MRI will not only show you the torn ligament, but you can also use it to look for signs of early degeneration. On the sagittal cuts, look for that dorsal subluxation of the scaphoid. When you see this, I feel this is somebody you can help. And this has been shown by the group at HSS in New York that the correction of the dorsal translation was the most sensitive predictor of postoperative pain relief, more so than scapholunate gap, radiolunate angle, or scapholunate angle. The next thing when I'm considering somebody for a reconstruction is whether or not they've actually already lost range. If their wrist is already quite stiff, then I think you have less to save, and perhaps they're better directed towards some type of a salvage, because the goal is to preserve range and prevent the loss of function, as would happen with scapholunate arthritis. However, if they've already lost range, then maybe it's already too late. I love these questions by Garcia Elias in terms of trying to frame your thinking about this problem. And I think forcing yourself to ask yourself these questions with each case will make sure that you're choosing the right patients and the right procedure. So the first question is whether or not the cartilage is preserved. So if it is preserved, or it's just at the tip of the styloid, you can probably proceed. You may or may not need to excise the styloid tip. However, if they already have advanced changes, then you're looking at some type of a salvage. If you're unsure, you can assess the cartilage either with an MRI or with a scope. Next is whether the carpal alignment is easily reduced. And I think this is the most difficult thing to determine preoperatively. We will talk about, they should be easily reduced. Don't push too hard. If the K-wire bends, that means you're putting too much force on it to get your reduction. And that is something that you will unfortunately need experience, but you will in time, as you do more of these, get a good sense of that. The important thing is if you have a patient with a static DZ, that you have that discussion ahead of time and explain to them that when you get in there, it might not be easily reducible, in which case your reconstruction may fail and they may be better served with a salvage. So that's something that you would need to discuss and make sure the patient is ready for. Is there something there that's repairable? If there is, you can certainly repair it, either open or arthroscopic. If there's enough tissue there to go after, go ahead and repair it. That's thought to prevent slack OA. If there's nothing there, if the scaphoid is bald, then you need to look at a reconstruction. So normal cartilage, reducible, and no tissue. Consider the patient before you offer them this surgery. How old are they? Do they understand what's expected of them postoperatively? The rehab time is long. This does not necessarily prevent slack OA. They may still need secondary surgery. And explain to them that they will likely see an increased gap again, but as long as that dorsal subluxation is corrected, they will likely do well. For those that are not up for that, salvage is certainly a reasonable option. Make sure that they understand this cannot be undone. They are sacrificing something, whether it be range, strength, longevity, activity participation. It's considered a last resort. But it is also one procedure that will likely give predictable results. So some people are not up for a reconstruction with a chance of potential failure. So you do need to understand your patient's wishes. This is a case example of a 45-year-old nurse who I saw several years ago. She had a static scapholunate diastasis with dorsal subluxation of the scaphoid. We offered her a 3LT, and that is my preferred technique. It's reproducible in my hands, and I've been pleased with my results. You use a distally based strip of FCR and pass it through the scaphoid across the lunate and back onto itself with some tensioning. And this lady did very well. A year post-op, no pain, near full motion, 65 flexion and 70 extension with equivalent strength bilaterally. This is a younger gentleman, 18 years old, high-level hockey player, has static deformity. This is his resting film, and he is not interested in a salvage. He was the one with the bent K-wire. So as I was trying to reduce it, I felt that this was a bit excessive, the force that we had to put on it. But with our preoperative discussion, I knew that he did not want to consider a salvage. So he was ready to go through with this, understanding that it might stretch out over time. Nonetheless, he did well. He was able to return to sport and showed good x-rays at 6 months. He then moved, so I haven't seen him since, but I also know that he is still playing well. This is a case where the difficult to reduce scaphoid didn't do as well, and we over-released it, and he unfortunately developed AVN. Now he's doing fine, but that's only through successful conversion to a 4-corner. The understanding has to be there preoperatively that if you push the envelope, there are potential consequences, and they are likely looking at a salvage. Why did those other ones do well? Well, I think that even though they may diastase over time, that dorsal subluxation is corrected, and that is the key. This gentleman had a dynamic scapholunate instability, and I've gone on to trial some of these techniques which which reconstruct the volar portion of the ligament. And this is a technique that's described by Kakar and Garcia Elias. And I'm also very pleased with this technique. And this patient also did very well. Slightly stiffer, I think. The volar and dorsal approach is a bit more traumatic for the wrist, and perhaps arthroscopic approach, if you're doing volar and dorsal, may be more suited. Now, another one, this gentleman's a little bit older, already has extensive degenerative change, and we offered a 4-corner or PRC for this gentleman. Now, and either of these are fine, particularly if the midcarpal joint is preserved. My preference is to do the 4-corner. I like this procedure. I think it's gotten a lot of bad press related to the complications, but I think those can be managed with meticulous technique. They will have a lower risk of progression of radiocarpal arthritis. I don't think the capitate was meant to articulate with the radius. And of course, when you have a younger patient with heavier demands, that's an issue because the PRC will have a finite lifespan. I do use the PRC for older patients, patients that need to preserve range and value that over strength and longevity, or those with a high risk of non-union. A systematic review looking at over 200 cases showed a higher complication rate with 4 corners, but really equivalent range and strength with about a 10 to 15 degree difference in flexion extension arc and about 10 to 15, less than 10% for grip strength. This is something that we've done at our center. I've basically looked at my cases, and hopefully this will be published soon. It's in the process of revisions, but we basically thought that the fixation method for your 4-corner matters. And we looked at our series, which was over 60 patients. Early on in my career, I was using staple fixation, but then transitioned to headless compression screws. So this is a comparison of those two. We found that our flexion extension arc of motion was not significantly different pre-op to post-op for patients that had the headless compression screws, whereas those that had the staple fixation lost a significant amount of motion. If you looked at their pre-op arc to their post-op arc for the headless compression screws, many gained motion. Grip strength was slightly better following the compression screw versus the staple group lost range, although this was not statistically significant. Our fusion rate was higher. Our length of time in the cast was shorter. and our time to union was also shorter in the headless compression screws. Obviously, we had no comparative group. I can't tell you if they would have done better with a PRC. Small sample size at 60, but I think for the four-corner literature, that's not that's fairly acceptable and quite a good number actually. And we had no patient-rated outcome scores. Some technical tips. There will be a lot of compression at the mid-carpal joint. So take a good 10 millimeters off your screw length. Put your bone graft in first before you implant the screws, and reducing the 2 columns is enough. With this technique, I've had excellent results and really low fusion rates. I try to do a very ulnar start point for my screw to preserve that cartilage to reduce the risk of degenerative change. Make sure the lunocapitate relationship is restored. So in summary, I think for scapholunate injuries, we can all execute surgical techniques. The most important point is to choose the right patient. So the history and physical are very important. It allows the relevance of the imaging and the arthroscopic findings to be put into context. Assess the status of the cartilage. That's going to determine whether you should save them or salvage them. And make sure the patient understands what they're getting into, and have a plan B if the scapholunate is not reducible intraoperative. Know what the patient's wishes are, whether they are okay with you proceeding, knowing that it may fail over time, or if they would like you to do a salvage procedure at the same time so they save themselves a second operation. So as always, I would stress that the clinical exam is the key, and make sure that your patient's expectations are in line with what you can offer them, particularly with this problem. If we can reduce that scapholunate dorsal subluxation, hopefully we can prevent arthritis. Thank you very much.
All that in 12 minutes, that's really fantastic. That's a lot of information. And I'm sure this is going to be on OrthoTV for us to get back to and listen to it again, because there's so much that you've distilled in those 12 minutes. Thanks a lot, Ruby. Any questions, Anil?
Nothing yet. Yeah.
Rohan?
Dr. Warrior, not as yet.
No questions?
Not as yet, yeah.
I have a question for Ruby. That was fantastic. I saw one of your images, your 3T, it looked like a distal bone tunnel in the scaphoid, and then another one, it looked like your exit point was at the proximal pole of the scaphoid, adjacent to this, where the scapholunate ligament would be. Do you have a preference, and why?
So I will use a dorsal approach. I put my drill from dorsal to volar, exiting into the, so starting where I want the tendon to come out and exiting at the tubercle. Make up the question.
And where would, sorry, and where would you want the tendon to come out?
Oh,
once you extend, once you extend the scaphoid, where would you want the tendon to come out?
Yeah, so I first do my reduction. So I first reduce the scapholunate, pin it, so that my scapholunate is reduced, and it's where, so I have the proper relationship of the scaphoid and the lunate, and then basically just, there's not that much room there, just basically so it can go straight across to the lunate. But it's hard, there's not a lot of real estate. So once you put your pins in to reduce the scapholunate, plus you have to get a tunnel in for your graft, it's tight.
Oftentimes I find, sorry, Chuck.
I was going to say, thank you, that I've seen, like you, I've seen AVN of the scaphoid from some of these reconstructions. And I try to avoid putting too much hardware in the proximal pole of the scaphoid. And so Brunelli, in the modified Brunelli, the bone tunnel was distal parallel to the ST joint. And when you pull up on the graft, it horizontalizes the scaphoid. And that's my preference, but I know that lots of people do it the way that you described. Your results look awesome.
Thanks.
Yeah, what I was going to say was, oftentimes when you've done your tunnel and you've got the ligament across, the tendon across, it seems to rest on the distal margin of these bones.
I don't think it matters too much, to be honest. I think the key is to reduce that dorsal subluxation. If you think of the anatomy of the radius, the scaphoid fossa is quite broad. So if the scaphoid slides radial, that's okay. There's lots of room for it. What you don't want is for it to slide dorsal. So I think as long as you correct that, don't panic if you get a bit of widening post-op. They'll still be happy.
Sumedh had a comment.
Yeah, it's just a quick thing, really. Like Chuck, I prefer to go more distally because I find that that little extra bit of tendon beds the proximal pole down. We don't use as many wires as Ruby does. In fact, we tend not to wire them or X-ray them because it's just humiliating when that gap opens up on table. So one of the things we've started doing is moving more and more distally. So you have a more direct approach down to the tubercle, as it were. So we don't go from pole to pole. We probably go from waist to tubercle. And that part of that tendon that then comes out and goes under the radiolunotriquetral ligament beds the proximal pole down. I think it's probably optimistic to think that all that stays in place, but it makes me feel good. So that's what we've been doing.
So I've known Sumedh for a long time, 30 years, and I've learned 2 Yoda-isms from him today. Number 1, never X-ray your scapholunate reconstructions, and number 2, if your scaphoid doesn't heal, it's a proximal pole. Well played, sir.
Well, I think if you X-ray them and you look at the lateral and you're only interested in the lateral, I think you'll be happy. That ICU nurse that I showed her 1-year X-rays, I should have included it. I actually just saw her recently. Now it's been about 8 or 9 years, and she has CMC arthritis, but she has gapped a little on the AP, but that dorsal correction is still there. So, you know, I think if you stop looking at the diastasis, you'll be happy with your post-op X-rays.
Does anyone do a razzle? Any of you do a screw? That's my operation of choice. That's why I asked.
We do it for the acute. We do if you have a acute scapholunate in some of the athletes, we stick something like a Herbert screw in and then with a plan to take it out, but I haven't done it for a chronic procedure.
I have done it and the result seems to be good.
Yeah.
Ruby,
At least the patient never complained.
Sumedh, you said with the plan to remove the screw.
Oh, we do remove the screw. We do remove the screw.
Okay.
Ruby, a basic question. Where do you measure your scapholunate distance? Is it in the middle or is it in the proximal area, especially in the dynamic kind of scapholunate?
Yeah, that's an interesting question because depending on where you measure it, it'll look different, particularly as a scaphoid starts to curve there. So I try to do it more in the middle, but.
Ruby, what do you think about this thing that I was taught many years ago? When you're trying to reduce the scapholunate distance, you don't use 45 wires because they bend. You use 62 wires, which is 1.6 millimeter. And
Yeah,
and if those bend, don't bother reducing it because it's never going to reduce.
Yeah, but you know, there's some people like that guy I showed you, and that happens. They don't like, they're really hard to reduce. But I think to some extent you still correct that subluxation, so they're happier, and it will gap. But I mean, there are other people where on the spot I will do, like, I'll consent them for both, and I do most of these surgeries under a block, so they're relatively awake. So, you know, I have had the pre-op discussion, but intra-op I have converted to a 4-corner without issue.
Yeah. Exactly.
Yeah, if there are no further questions, we'll go on to the next talk, which is by Becky about rehabbing scapholunate injuries.
My second talk for this evening is on rehabilitation following scapholunate ligament tears. When we think about conservative management of scapholunate ligament tears, we think about grades 1 and 2, and we think about holding these wrists until they're stiff and stable, immobilizing them for approximately 3 up to 12 weeks. This can be done with a thumb spica orthosis like the one you see on the right. Then we begin to immobilize intermittently. So we have the patients do exercises and then return to the splint between exercises. When we think about conservative management, we also think about initiating gentle active range of motion, such as the dart thrower's motion, which I will go over in just a second. And those are the photos that you see on the right. We start passive range of motion judiciously. We really want to think as therapists about the goal being stability over mobility, especially after a ligamentous injury. And we want to be really cautious about strengthening. So we can think about isometric dart throwers motion. And when you think of an isometric contraction, it means an equalizing contraction against resistance. And we also think about taking caution with power grip strength. So what is the dart throwers motion? It's an active motion, which kind of in the United States, we play a game called darts. And I'm not sure in India if there's a similar kind of activity or hobby, but it basically is a small little dart that you're taking and moving or throwing forward. And so what you see is the movement from the radial deviation and wrist extension towards ulnar deviation and wrist flexion. So from here to here, from here to here. So this motion has been studied extensively and really thought that most functional tasks are performed in this plane of motion. With this motion, more action occurs at the mid-carpal joint, thus decreasing the stress at the radiocarpal joint. So we're really thinking about where kind of motion is occurring and how much stress is being placed on the scapholunate ligament. There has been found to be less motion of the scaphoid and lunate, and this has implications for early motion protocols for fractures, for scapholunate ligament injuries, and for ligament repairs. So when we think about therapy post repair or reconstruction, things change a little bit. And so here is a more solid or stable thumb spica splint on the right, could also be a cast. Your therapist does need to know what type of surgery was performed and what the implications are for treatment. So for the open reduction internal fixation, therapists usually start motion between weeks 4 to 6. For the dorsal capsulodesis, we're going to really think about monitoring stability prior to initiating passive range of motion. And in the cases where there's a bone ligament bone graft, we're going to take caution with early loading of the patient. So again, this reinforces the idea that it's very important for your therapist to know as much information about surgery as possible. The patients that are postoperative will be in a thumb spica cast or orthosis for up to 8 weeks. And their education is important because we want to make sure that patients understand the expected outcome and the concept that they may not have full motion of the wrist when all is said and done. But we also know that patients don't need completely full motion of the wrist to be functional with their activities of daily living. And so this education is incredibly important. Again, our goal for the postoperative scapholunate repair or reconstruction is stability over mobility, especially in the early phases. So thinking about post-op rehabilitation, as I said before, 8 weeks in a cast or orthosis, you see both options at the right. And then we move the patient to a forearm-based thumb spica orthosis for an additional 4 weeks once therapy is started. Similar to conservative management, that the patient can take that cast or the orthosis, on and off between exercise to increase the stability. It's really interesting when we think about scapholunate ligament tears, there's been a lot of energy directed towards kind of the brain-hand connection in this literature and the idea of using different opportunities to help the brain connect to the wrist and to the hand, thinking of all those proprioceptive elements in the wrist complex. And so when we think about the early mobilization phase, we can begin with gentle active range of motion and going back to that dart thrower's motion. But we can also incorporate proprioceptive training. So thinking about joint position sense, using a mirror box and or visual influence. And so on the top left photo, you see a mirror box. These are very easy to construct and there's lots of YouTube videos. But the idea here is that you're tricking your mind into thinking that you're working both hands and really trying to get that wrist and that hand to function, helping the patient neurologically see the wrist and really be working on function. The bottom, what you're noticing is this is kind of a proprioceptive input game. And what's happening here is this gentleman is using a Frisbee to actually move a marble around the circle. And again, we're really working on that proprioceptive input, thinking about wrist in space, thinking about how the input of the proprioceptive fibers is going to help us better control wrist motion. And of course, just like everything else, any post-op case, we're going to do scar management. So passive range of motion for the patient who's postoperative will begin a few weeks after active range of motion. Your therapist is going to be gentle. They want to make sure that they're not going to destabilize the repair. And again, I keep saying this over and over, but stability over mobility is our main goal. We can use or move towards strengthening when the patient is pain-free and has good mobility. Again, going back to those isometrics and dart throwers motion, working to isotonic, so against resistance with motion. Perturbation exercises, I think it's really interesting to think about what that is. And so that is actually disturbing motion with some kind of outside destabilizer. And so there's a little tool called a gyroscope that basically fluctuates in your hand. And having the patient try to control the gyroscope, again, goes back to that proprioceptive input and trying to really use that brain-hand connection to control motion in the hand. It's a really cool little device. And then finally, reactive muscle activation. So you see the patient here pushing on kind of this little ball. And what's happening is here is trying to really have the wrist respond and have the muscles activate in response to putting pressure and kind of destabilizing the joint in this photo. And so as you see, there's lots of very interesting options and ways that your therapists have at their disposal to help treat the patient post-scapholunate ligament reconstruction, both conservative and surgical. Thank you.
Thanks, Becky. There's so many new things that have come out of that. The dart throwing plane is something that's been around for a long time, but a lot of therapists in India probably are not aware of. So when I write that and send it to the therapist, I do get questions from them. And just as you were speaking, Nikita sent me a message saying we should tell them that it's exactly the same range of movements that you would do when you throw a paper aeroplane that you create and you throw it at your teacher in class. And that's the dart throwing. That's absolutely perfect, Nikita. That's wonderful. So maybe we can just discuss that with the therapist. It's much easier than trying to tell them what the dart throwing plane is.
And a worldwide phenomenon, right? We all throw the
Oh, yes. And also the Frisbee, it was very interesting. The gyroscope, of course, depending on availability, but the Frisbee is a very, very interesting concept.
Mm-hmm. I will say it's important. The dart thrower's motion is controversial. And so there's a really good study by Garcia Elias in 2014 that found for your scapholunate ligament tear, if it's not repaired, to take great caution. Conceptually, dart thrower's motion also can be either functional or true. And the true dart thrower's motion is really the motion in the plane with no type of active function. Functional dart thrower's motion is doing it when you're actually doing something like using a hammer or drinking from a cup. And so there's been some good studies of the differential between true and functional, with true being more cautious and careful, and a range that the therapist can modulate. So we don't have to go through full range of motion, knowing that that can increase the gap or the widening between the scapholunate ligament, the scapholunate interval. And so making sure that therapists understand not only the grade of the tear, if you feel like it's safe for the patient to do true dart thrower's motion or that true plane, orthogonal plane, and then also post-op, dart thrower's motion can be modulated as well. But it is very interesting literature, and there's quite a bit of literature on the topic.
And this would all be relevant to the scapholunate injuries only. But otherwise, the dart throwing, the plane is absolutely wonderful when you're rehabbing other conditions of the wrist. But when you're doing it for the scapholunate, you need to be careful, as you mentioned. Any other questions?
None on the chat right now.
Okay. Becky, how much of thumb immobilization is required when you start your rehab?
I think that's a good question. And I think, again, when we were talking about scaphoid fractures, I think the question becomes, in your opinion, as the surgeon, the stability of the repair is going to be important. If you would ever let me put the patient in a wrist splint without the thumb involved, when I think about the scaphoid, we know that the trapezium, obviously, and anatomically, the trapezium is sitting on the mobile scaphoid, and the scaphoid is going to be that intercalated segment to transmit motion from the distal to the proximal row and vice versa. I think your surgical perception of stability, especially after a ligament repair, because we know that we're going to have to transmit forces through that ligament for full wrist range, I would want your input on whether you believe it's safe to move that thumb, that mobile trapezium on that scaphoid with any type of resultant motion. But I would love to at least, again, get good wrist IP motion going, potentially even MP motion going, and try to stabilize the CMC if that's what you prefer.
Right, if there aren't any further questions, we'll move on. And I'd now like to introduce Sumedh Talwalkar, a dear friend who trained at the KEM hospital in Mumbai and who comes from a great line of orthopedic surgeons, some of the greatest orthopedic surgeons in our country. His grandfather, in fact, started the collaboration and started the implant companies in India and designed fabulous instruments and implants, many of which are still in use quite successfully. Sumedh currently heads the hand surgery at Wrightington. I had the opportunity of visiting him and enjoyed his hospitality. And when he's home, which is not very often. He's very, very busy. He loves to cook and he loves to feed people. I enjoyed that. Thank you, Sumedh. And he's going to be talking to us about CMC arthritis of the thumb.
Many thanks for inviting me to this meeting. I'm going to focus on current concepts in the management of basal thumb arthritis. These are some of my interests. In terms of prevalence, we know that basal arthritis is common. A third of all women and a fifth of all men in their fifth and sixth decades will go on to develop osteoarthritis. I'm going to touch upon the classification system. We'll speak a little bit on the anatomy and follow that with total joint replacements. The ubiquitous Eaton-Littler classification is a radiological classification in 4 stages and is very commonly used for the diagnosis and classification of CMC joint osteoarthritic change. However, the classification system has significant limitations. Due to the obliquity of the trapezium in the coronal and sagittal plane, profiling the thumb joint radiographically can be difficult. There are discrepancies between the radiological appearance, what we find at surgery, and clinical symptoms. And more importantly, this is difficult to use as a classification system to guide treatment. The thumb osteoarthritis index, on the other hand, seems to do better. And this measures the ratio of the trapezial width with the trapezial height as obtained from the Robert view. The ratio increases with disease progression and seems to predictably correlate well with joint degeneration, as is more reliable than the descriptive Eaton-Littler classification. A little bit on etiopathogenesis and anatomy. We know from looking at the anatomy that the CMC joint is congruent and at extremes of motion has very little intrinsic stability. The stability itself at the joint is maintained by 3 main components: the volar oblique ligament in the front, the dorsal ligament complex dorsally and its 3 components, and the intermetacarpal ligament ably supported by the volar thenar musculature. Pellegrini suggested that localized degeneration of the palmar beak ligament and its metacarpal insertion is a specific and critical pathological event in trapeziometacarpal arthritis. Is this true? Let's look at the evidence. Now, this is the appearance of the thumb base in the resting position. The prominent volar beak of the thumb metacarpal is disengaged from its recess in the trapezium, and the TM joint space is relatively large. Both the volar beak ligament and the dorsal ligament complex are lax. But during a power pinch with a screw home torque rotation, the dorsal ligament becomes taut. The volar ligament becomes even more lax. The joint is compressed and the beak of the thumb metacarpal is compressed into its recess in the trapezium. This forms a dynamic force couple that changes the TM joint from a position of incongruity and laxity to congruity and rigid stability. During cadaveric dissections, you can see that the volar beak ligament is thin and translucent, and you can even see the dissector underneath the ligament itself. It tensions at maximum volar beak disengagement in the hitchhiker's position, and we've shown that it's completely lax in the screw home torque rotation phase of opposition. So it's increasingly felt that osteoarthritis at the base of the thumb is not due to ligament instability or degeneration of the volar beak ligament, but instead due to the concentration of compressive shear forces during the power pinch. The instability comes much later with advanced arthritis. Why is this important? I think it's very fair to say that for decades, surgeons have been compensating for patients losing their motion following trapezectomies with different methods. A persistent weakness after simple trapezectomy has provided an impetus for the development of many ingenious methods. Eaton and Littler set the ball rolling when they devised a ligament reconstruction based on an FCR graft. This was followed in 1986 by Burton and Pellegrini, who began the era of ligament reconstruction, or the LRTY, using the FCR or the APL tenodesis. Surgeons believed that they were reconstructing the volar beak ligament, as it was considered to be a key ligament in stabilizing this joint following a trapezectomy. Many ligament reconstructions have been proposed, and some of them were quite complex. And this was until Tim Davis produced his landmark paper, which seemed to indicate quite clearly that there was no difference between the humble trapezectomy and some of these complex ligament reconstruction procedures. So what do we do in Britain? In a recent survey that I conducted, the numbers are quite low, but trapezectomy and sling procedures, or just trapezectomy on their own, seem to be by far the commonest surgery for this form of disease. But a significant number of people have now started doing joint replacement surgeries. I personally perform a simple trapezectomy with a Wyss sling using the FCR graft, which I loop around the abductor pollicis longus. This is in order to build a hammock-like structure to suspend the first metacarpal and prevent collapse. But this is what is happening in Europe, where the trapezectomy and ligament reconstruction seems to be on the wane, and nearly 75% of procedures appear to be total joint replacements. So is there the evidence for that? Like all stories with joint replacements in the hand, this too begins with the Swanson's prosthesis, which was used as a spacer. When the hip joint was popularized in the 1970s, cemented replacements came in and were associated with loosening. And the 1990s inevitably brought the metal on metal phase. Currently, we have modular, anatomical, uncemented third generation prostheses. There have been notable winners and quite a few prostheses which were withdrawn for various reasons. And it's fair to say that there have been issues surrounding the high rate of dislocation and loosening of the trapezial component. The third generation prostheses now have dual mobility concept with a retentive PE liner with two concentric articulations. The smaller one is represented by the neck extremity moving against the PE cup, describing the greater arc, which is represented by the PE cup moving against the trapezial implants. So in theory, you have a larger head and a greater arc of range of movement. This has some advantages, one of which is the jumping distance. So the prosthesis has to longitudinally move through a greater distance to produce a dislocation, which gives you an advantage. Additionally, there's the issue surrounding the proper distribution or the greater distribution of forces across the interfaces, reducing shear forces at the bone cup interface. But there's no such thing as a free lunch. And we know from our experience with the hip joint that intraprosthetic dislocations can occur. And there's also the problem of volumetric polyethylene wear. Looking at the cups, you can have a spherical cup or a conus or a coned cup. The cone type configuration has the additional advantage of having a greater surface area for the same diameter, which allows for greater bone ingrowth. We prefer the offset neck, 15-degree offset. This is to prevent incorrect medialization of the metacarpal axis. A number of prostheses now, including the touch prosthesis, uses highly cross-linked polyethylene, which has a better wear profile. So what does the literature say? Let's look at the RPE, which has been around for a long period of time. And Martin Ferrero's paper showed a survivorship of 93%. But interestingly, in the same journal and a few pages later, we found another paper which showed that the survivorship for a smaller cohort was 85% at 10 years. There were lots of problems with technical errors, with a significant learning curve. It was felt that the implant survival declines with surgery over a period of time, and the surgery the authors found was difficult to master. They also said that they advised selecting this implant with caution. The Maya prosthesis from France has been around for a long time, with a good prognosis, with lots of literature behind it. The Movis is relatively new. It has the additional advantage of a short microplasty stem with good 2 to 6 year follow-up rates. There is a tendency to blame the implant design for failures. but one has to underscore the importance of very careful surgical technique and the precise instrumentation required for trapezial implantation, as well as the extensive soft tissue release. There are patient-facing factors regarding heavy repetitive work and poor bone stock. The extended learning curve is an issue as well. Looking at the trapezectomy versus total joint replacement, there have been numerous papers looking at the same, but these have short-term follow-up of 6 months to a year. They're retrospective studies or case-controlled studies. The only study which is prospective and randomized was associated with high revision rates and was abandoned because of the fact that the prosthesis was withdrawn. We know for a fact that the LRTI and trapezectomy do provide good pain relief in about 85% cases, although there is an associated weakness. When you think about what our lower limb colleagues had to contend with, clearly the girdle stone procedure itself was completely unacceptable. However, for a trapezectomy to succeed, we have to be able to prove that the increased cost of the implant provides that additional benefit given the obvious issues surrounding the risk of complications. We know that the reported survival is now between the 85 to 95% rates, but there is no benchmark for acceptable or poor survival rates. A number of our cases which are there are prone to publication bias, and clinicians and editors are more likely to publicize good results rather than bad. So for this exciting development to succeed, prospective data registration, planned long-term follow-up examinations need to be considered with reduced dropouts, and this will improve our accuracy and estimates. Thank you.
That was fantastic. The big problem for India is that we don't have a good joint yet. At least I don't. I don't know if Binu and Anil have a joint that they've been using, but I don't have access to a good joint. Much as I'd like to try out some of those, especially the ones that have shown promising results. Not because the LRTI has any poor results, but like you said, whether you just take out the trapezium or you do an LRTI, you're going to get almost the same result.
It's just that the point that I made in the last two slides, I was running short of time. So I wanted to labor on that a little bit. And that is that with the lower limb, the girdle stone is such an awful procedure that anything, just about anything would have succeeded. In many ways, that's why the hip replacement or the knee replacements, these are procedures that didn't have a worthy opponent, as it were. While when it comes to thumb-based surgery, the trapezectomy is a perfectly good method of treating the problem. It's a cheap method of treating the problem. And there are some issues that are attendant to it, namely the weakness of grip. And for a joint replacement to succeed, you've got to prove that the additional costs, the chances that, the risk-benefit analysis in terms of what's going to happen if something goes wrong, to be able to prove that is going to be a uphill road. And, it really needs to be done responsibly by people. And that's why what's happening in Europe, it's quite unusual what's happening there, because I think the US is at par with UK in the sense that you've been very cautious with what you've been doing with base of thumb. But I think as far as Europe is concerned, trapezectomies are being done less and less without any evidence. But that's my opinion. That's my opinion.
Sumedh, about 30 years ago, Howard Beddoe from Liverpool and his then registrar Sunil Dar published what I thought was a wonderful paper on the long-term results of trapezectomy, nearly 100 cases of Howard Beddoe's cases. And that paper has been lost to obscurity for some strange reason. Why do you think that is?
I don't know. I think what's probably happened is because the LRTI craze took over, and because what happened with Beddoe was it was a retrospective study. And then what Tim Davis did was to do a prospective study, and he was criticized for it. And there was a lot of emotion, and he was very unhappy that he was criticized. And then he immediately published another cohort. So because of all that excitement, Mr. Beddoe's work has been largely ignored. But I completely take your point. Yeah.
Do you see a role for basal joint osteotomies in your practice at all?
We don't do them. We don't do a lot of them. So we have a unit in Liverpool at the Wirral, where John Stanley's, I think there was a chap called Simmons who used to do a lot of base of thumb osteoarthritis osteotomies. And the people who've taken over from him, they do a few osteotomies, but that's just 1 or 2 centers. As a rule, we don't seem to do as many in the UK.
What about arthrodesis, Sumedh?
Yeah, in the younger individuals in isolated base of thumb disease, I think an arthrodesis is an excellent procedure. Obviously, you have the 30% chances of non-union. It's not something that you take lightly. It's a difficult surgery to do, but it's perfectly acceptable, I think, to do an arthrodesis. You just have to tell them that they won't be able to put their palm flat on the ground. That's really very important that they're aware of that. And if they have any STT joint disease, then you've got a problem later.
It's quite surprising that you mentioned about the fact that they can't place their palm flat on the ground.
Yeah.
And the other thing is you can't put your hand into your pockets easily, maybe get into corners behind the television if you need to get your hand, etc. But there's a patient whom I've seen who's a orthopedic surgeon himself, operated by PC Ho, arthroscopically and fused, and he can do
everything,
damn nearly everything, and he can keep his palm flat. I've got pictures of him. It's amazing. Maybe I'm missing a trick somewhere when I fuse my CMC joints.
Or orthopedic surgeons are exceptions.
Or
There's
maybe
an audience question on CMC, role of CMC tightrope.
So the tightrope it should be renamed to, we should call it just right rope. I mean, I don't know whether you were there for the CME in India. So it shouldn't be called the tightrope. So if you do this particular procedure in someone who is young, a high demand person, you do a trapezectomy in them, then we use a tightrope which runs between the first and the second metacarpal. The downside of it is that if you put it in too tight, you end up with impingement between the two. So you exchange again, you end up with a pain exchange mechanism where they have a lot of pain. So you've got to get it just right so it hinges at that particular level, and then fibrosis takes over. I've done very few of them, and only in those cases where they were indicated. So I don't do it as a primary procedure. There are a lot of people who have started doing that. And you know how commercial pressures are all over the world. So I wouldn't recommend that at all as a primary procedure. The humble trapezectomy, as I've said, and I would obviously we'd like to know what the rest of the faculty feel, but I'm yet to be convinced that there's anything better than the simple trapezectomy. I use the Wyss sling to sort of support the metacarpal, and we get a number of senior fellows. They like doing the sling, which is not a good enough excuse to do the sling. But if I was given half the chance, I think a simple trapezectomy would do well. And increasingly with Valant, when we do it wide awake with local anesthetic, we just do a trapezectomy.
Sumedh, sorry, go ahead.
There's a question from the audience, Dr. Sumedh. Dr. Srikanth Ravindran from CMC Vellore. He asks you, does the arthritis of the trapezoidal joint influence your choice of surgery?
I mean, again, when you do a trapezectomy, if you have arthritis in between the two joints, we take a bit of the trapezoid off if it's required. There's usually an osteophyte in that region, and that very often takes care of the problem. But it doesn't influence my choice. The surgery of choice again would be at the moment, although in selected cases we will start doing joint replacements, but that's more because you're anxious that you don't want to be left too far behind the latest bandwagon, and you've got to be careful of how you've got to choose your procedures carefully.
Sumedh?
Yes.
Guardiola and Gelberman had shown that there is postoperative subsidence of the metacarpal within the first year of about 3 to 4 millimeters.
Yes.
Do you think that that's replicated in the UK, and do you think it's worth being concerned about? Are you okay with it?
So the collapse of the first metacarpal is inevitable. Why some people end up with so much pain and why others have no pain at all is something that I can't explain. So that really is the key thing, that the radiological findings don't really key in with what we find symptomatically. And if we were to find out what the cause of that was, because I think when you take that intermetacarpal osteophyte out, that's the intermetacarpal ligament finished.
Yeah.
Essentially what you've done is you've created a metacarpal which is floating in space. And it's only a matter of time before it's going to settle. And anything and everything that you put in between, whether you do it arthroscopically, whether you do it open, or you do it with mind control, I think that's going to collapse with time.
But not taking out that osteophyte also suggests that you might have trouble in the future.
Absolutely. Absolutely. That has to be taken out. Yeah.
I think we could have a whole session on this particular subject. Sumedh's talk is fantastic. And that was a great point that you brought up. It's a great operation, except when it's not.
Yeah.
And when it's not, we assume that it's due to subsidence, right? We treat subsidence when we do revisions, which may or may not solve the problem. But I've taken care of a number of patients who've had the internal brace treatment alone without any biologic augmentation whatsoever. And I don't have a denominator, but they don't do so well. But I think some people are using it as in lieu of a K-wire, for example, a trapeziectomy, holding it out to length for a while, expecting that it's going to fill in with something. But I don't use it personally.
There have been those who have published even using 2 tight ropes.
Yes. So I mean, it's a very commercial procedure, isn't it? That I wouldn't recommend even one. I just do it for those situations like Chuck said, where you have it's a failed trapezectomy and they come to you with pain. That's the only place where I think there is a role for it. And it's just right rope. It's not a tight rope. That's more important.
Just rope.
Just rope, yeah.
Dr. Warrier, there's a question from the audience, again by Dr. Shrikant. Any experience with the Cartiva spacer implant?
Yeah. So all these spacers that have been used have had various success rates in the past. But I think in some, and this is my view, it's my personal view, is that in many ways that's a sort of a lazy option. It's like sticking a bit of pyrocarbon in the middle of the lunate, or doing a wrist replacement with a bit of pyrocarbon. The first CMC joint deserves a little more respect than that. That's what I feel. Over a period of time, we'll see that there is no advantage to doing some of these procedures. You have to pay attention to biomechanics, but the people who published on it seem to think that they do well. I haven't personally done the Cartiva, but there are some centers, particularly around Southampton in the south of the country, where they've used the Cartiva to good effect.
I was an investigator in the Cartiva study, and I could not bring myself to enroll a patient in it. I just couldn't do it. It's like an eraser head.
Yeah.
Yeah.
I was in Russia and I was handed a few ceramic joints, which I could bring back and use, and I left them there and came back. I didn't have the guts to bring them home.
Yeah.
We'll move on to Becky's talk, and I think I do a pro bono clinic and surgeries with Nikita at a very distant place from where I am in Gujarat, very close to Bhuj, where the earthquake was. And over the years, we've been seeing so many CMC joint arthritis in that area that it's amazing. Every time we go there, the old ladies will come back, but they will not get any surgery done. And they'll bring me lovely things that they made with their own hands. And I think Becky's lecture is going to highlight how you can do this.
My final talk for this evening is on rehabilitation for first carpal metacarpal osteoarthritis. The first CMC joint is a prevalent location for osteoarthritis in women more than men. And we know that the thumb makes up to 50% of hand function. So it's a really important diagnosis, especially for the patients that are experiencing this painful condition. The CMC is inherently unstable due to the joint shape. And I think this is really interesting because when I taught anatomy, I would certainly teach the students that the CMC is this beautiful saddle shape. And actually, when you get into the literature, you find out that in many studies, they have found that it is a very incongruous joint that doesn't fit together, well, and it's sitting on the mobile scaphoid. And so when you think about all the issues that are inherent that could lead to CMCOA, we really think about kind of anatomically and structurally that this joint is not set up to be incredibly stable. We also know that the forces of pinch translate through the CMC joint. So the force of the lateral pinch is 12 times greater at the carpometacarpal joint than at the tip of the thumb. And this is really important to remember, especially for patients that have jobs that do a lot of pinching or require a lot of force. There tends to be wear and tear between the first metacarpal and the trapezium in these conditions, but that can extend to other joints and other bones as well within the carpals. Therapeutic intervention is determined by the stages of the disease process. Our biomechanical goals are to reduce inflammation and pain, decrease trauma to the joint, attempt to facilitate proper joint alignment. And I said with an incongruous joint, this can be quite difficult, and educate the physician on the condition and on modifications they can make in their daily life to decrease pain and increase function. There are basics to intervention. First is joint protection techniques. We'll go through those in just a minute. Modalities as appropriate. Things like paraffin and moist heat tend to be very relieving or calming to the patient, and they tend to really appreciate heat modalities in cases with CMC osteoarthritis. For exercise, we definitely want to work on pain-free range of motion and dynamic stability of the CMC joint. And I'll give you some examples of those concepts in just a minute. And then we have looked a lot at and thought a lot about and studied a lot about the types of orthoses that we can create and or prefabricated orthoses that can actually decrease stress on the first CMC joint. So the first thing I want to review is dynamic stability. And so if you look at the C position up at the top, we're really thinking about how to have the patient create this position as a way to really think about bringing that thumb into proper alignment. I often teach in anatomy the idea that the first metacarpal and the second metacarpal should not be parallel to one another. So having the patient assume the C position is really trying to engage that first CMC joint to really work towards opposition and abduction so that the patient is really stabilizing that first metacarpal into a more kind of approximated position off the palm of the hand. And so really moving it up and away from that second metacarpal and out of that parallel position. Joint distraction can be helpful, especially of that first, the second metacarpal phalangeal joint at the index finger, thinking about its connection to the first dorsal interossei, which is an incredibly powerful muscle. What we know in cases of CMC osteoarthritis is there's a huge disruption of anatomical alignment, and really trying to move patients back towards that typical alignment is what your therapist will try to do gently in the early phase. On the bottom right, what you're seeing, and I always find this a bit entertaining, is what we in the United States use to put chip clips on bags. And so when you have a bag of Doritos or potato chips, you often roll them up and put this little clip on them. So you'll find them in a lot of grocery stores around here. You can find them easily online. I also find it interesting that we find them often in our surgical and therapy conferences as giveaways on tables. And so what's happening here is this little chip clip is actually trying to create adductor release. We know that in the unstable CMC joint, the adductor is going to really try to pull that first metacarpal again towards that parallel alignment with the second metacarpal, especially when that first carpometacarpal joint is unstable or destabilized. And so this clip idea is really to try to decrease the force or relax that adductor pollicis muscle, which we know is a really good adductor and truly draws the first metacarpal towards the parallel alignment that we're trying to avoid. Exercise principles that were adapted from Valdez and Vonderheid in 2012. We know that the curved surfaces of the CMC joint provide little intra-articular stability. Strengthening of thenar intrinsics, thumb extensors, abductors, and wrist extensors can help maintain the first web space, avoid adduction deformities, and improve thumb stability. Lateral and key pinch strengthening should be avoided in patients who have instability and or deformity, because these exercises can result in further joint subluxation and pain. And the force applied to the surface of the trapezium as a result of thumb muscles firing to stabilize is between 6 and 24 times the applied load, depending on the posture of the thumb. The magnitude of these loads should be considered when performing resistive pinch and grip exercises. And so I think it's really interesting to think about the orthosis or the splint as an external construct or something we could put on a hand to help maintain the position of the thumb and decrease these destabilizing forces. Joint protection is the concept that we want to maintain muscle strength, range of motion, and endurance by respecting pain and having our patients use larger or stronger joints as they're able. And I have some photos to show you in just a moment. We want to help our patients avoid tight or prolonged grasp, avoid positions of deformity, avoid remaining in one position for a long period of time, balance rest with activity to conserve energy, and finally use adaptive equipment and techniques as appropriate. There are a lot of interventions and opportunities that your therapist can provide for the patient with CMC osteoarthritis in a conservative way. So joint protection, what you see here up on the top right is you're going to see the knife and a pen. And what we've done here is just built up the handles, and so made them larger so that those small muscles of the thumb, and so that the pressure or this destabilizing forces on the CMC joint are decreased. I want you to note on the position on this pen on the right-hand side, this is Coban. And so it's actually the Coban is creating friction and making it easier to grip the pen. And so this is a really easy, cheap, quick trick. So we built up the handle and added the Coban to make it to add friction and make the grip strength have to be less. What you see on the bottom is really adapting and helping people to think about different ways to grab and to cut. And so these are things we all do in our daily lives. And then finally, I don't know about over in India, but in the United States, we've got tons of these horrible grocery bags being handed out to people at every Walmart and grocery store and Target and all the different places people go to get their food and their groceries. And so basically what you see here is what happens is people tend to typically pick these up by their fingertips or their thumb, rather than using that larger elbow joint to support that bag. In my opinion, it would be great for our patients to use paper bags. We use a lot of those in the United States, but really thinking about these very small activities of daily living that can actually put great stress on joints is a great intervention your therapist can provide. And then orthoses, there's been a lot of literature and study on these. We look at the one on the top right and typically call that a short opponens or a hand-based thumb spica. What it does is unloads the CMC and palmar abduction and puts the MP joint in about 30 degrees of flexion. There's some good literature that looks at the idea of including the MP joint and the way it offsets the palmar oblique ligament or the beak ligament to try to decrease those deforming forces. And so the MP joint inflection is something that has been supported within the literature. There's a lot of questioning about whether the patient can do as well with a prefab splint versus a custom splint. Therapists are limited by the fact that custom splints are hard plastic and we can't really get around that. So prefabricated splints have been found to be as effective as our custom made splints. And so those are easily available online, I think probably globally, but it's a good question about what splints you might have access to in India. And then finally, a systematic review showed effects on pain for thumb CMC orthoses, but no change in strength, function, or dexterity. And so the hardest part about CMC osteoarthritis is we can use these splints to decrease pain and make patients, feel like they're more comfortable doing their work, but whether they will actually solve the problem of CMC osteoarthritis and change strength, function, or dexterity is a different conversation. And then there are cheap and easy ways. This is called moleskin, and it comes in rolls in the US. And basically, Paige Kurtz, a great friend of mine and a great therapist, has created just a really quick and simple splint for people to really kind of try to bring that first metacarpal again into that more kind of oblique alignment versus parallel alignment with the second metacarpal. So that ends this talk on all the interventions that your therapist can provide for the patients with carpometacarpal osteoarthritis.
I had asked Becky to give a talk for 4 minutes. This was 9 minutes, but I couldn't take a minute off. I tried editing this 3 times, Becky, but I didn't want to take off anything from this one. This was really, really fantastic.
I appreciate that. It's interesting when you have to do a 4-minute talk and you have so much to say, it's hard to cut that back. So thank you. And I apologize for going over time.
No, but it's really like just what I said earlier, that I would like to come back and listen to this again a little more slowly when I don't have so much of other things coming in, but it's really worth a lot for us. Thank you.
Hey, Becky.
Any questions? Yeah.
I had a question for Becky. Becky, going back to that paper by Wanderheid that you quoted, and you had 3 targets there. And the first target was to avoid the adduction moment, right? But I struggle with that so many times. My patients will come back to me after trapeziectomy or LRTI, and they say my therapist is not happy with me because I can't bring my my thumb to the base of my small finger, and I'm literally tearing my hair out because it's creating a cantilever mechanism, which I really don't want on the base of my first metacarpal. So how do we go about changing that culture?
You know, this is such an interesting question. And I think we change it all the way back kind of in these students I'm teaching right here in the School of Health Sciences, because I believe, and I oftentimes tell therapists, there are so many things we can modulate. It's not an all or nothing phenomenon. No. And we talked about this earlier with Dr. Cassidy's question about wrist flexion and extension. It's really empowering therapists and also patients that we don't need to go back to full, you know, what do we do with this? Like, what do any of us do with this on a daily basis? And so really, if the actual goal is function, the dash is a much better, you know, indicator of if our patients are going back and being functional. So really incorporating different tools, but also giving them permission that, and I learned this from the surgeons I worked with, it doesn't have to be a perfect x-ray for the patient to go and be functional. And so I think that would be, you know, permission to the patients and to the therapists you work with of, you know, knowing when to say when and being okay with, you know, patients that have good functional use and not trying to return all the way to crazy positions like this. I agree, absolutely. But I think we just have this perfectionistic, I think hand therapists by just are honestly very perfectionistic humans. And so I think it's just also giving them permission to say, we don't want to actually move to this direction, but that's a great point.
Yeah.
It's interesting. So there's this Kappanji scale, right, for range of motion. And I think to get 100, you need to get all the way over here. Yeah. So we're all overachievers, you know, we want 100.
Yeah, I keep noting that on all my papers, the Kappanji score, and that's 10. And barely anyone gets to 10.
10, yeah, that's it.
Yeah. If there are no questions, sorry.
The other is placing the hand flat. Patients get fixated on the fact that their thumb is palmarly abducted a little bit, you know, and they really want it to be flat. And I ask them, why? Why is that so important? It's going to stretch out eventually. Don't fixate on that.
So that's we have a subgroup in our town, Chuck. You and I know that, the yoga specialists. And to do the downward dog, you need that palm flatness, and they can't do that. And that's why, at least I have a few patients who are unhappy because of that particular event.
There's a market, you know, wedges are available for people who lack some wrist extension or their thumb. Yes. Oh, we should sell them in our office. Yes.
That's a good one. Are there any questions?
Dr. Warrier, none on Slido.
Right. So we'll go on to the case discussions. We're already running a little behind time. And I'd like to introduce Dr. Nikita Shetty. She trained as an observer with Chai. She got that opportunity on the Indo-US and conference meeting where Chai announced this, and she interviewed with a few others, and she managed to impress Chai. Went there. I don't know when she was there, whether she did, but she's back, and then she's back working with me for the last 3 years. She loves stay fit. So often I find her coming a little late because her fitness schedule was a little more than her surgical schedule. She also is training in classical Indian dance. She's a great artist, as you saw in my presentation, and I love her cooking. Nikita is going to talk take us through a case presentation.
Just a second. So this was a 56-year-old male patient, an active patient who would play sports on weekends, who presented to us with a history of fall on an outstretched hand with swelling and pain in the wrist and restricted painful movements with hindrance in day-to-day activities. And he presented to us 4 weeks after his injury with typical tenderness over the scapholunate joint dorsally, and the Watson test was painful, but there was no clump. These were his preoperative x-rays, which showed an increase in the scapholunate space as compared to the other intercarpal spaces, and the scaphoid was flexed with the increase in the scapholunate joint. And these were his preoperative range of motion, where here it looks like it's a good arc of motion, but the movements were very painful, and it was very difficult for him to go about his daily life with the pain. The MRI showed a clear, complete tear of the scapholunate ligament, with most of the ligament attached to the scaphoid. So the dilemma in this case that we had was, the positive points in this case were early pickup. He came to us just 4 weeks after the injury. He had a good scapholunate ligament attachment of the scaphoid with a good stump. And he was an active patient with a sedentary lifestyle. It was like weekend sports and weekend activities. But the points against a repair were that he was 54 years old. So I would like to put out the question to the faculty. If this patient came to you 54 years old, what would your primary choice of treatment be? Would you repair it, reconstruct it, or would you do a primary salvage procedure?
Nikita, 54 is not old. So we could start from there.
Sumedh, where we are speaking from, life expectancy is about 10 years lesser than where you are speaking from.
Nikita, you and your 2 sarcomeres will get there one day. So be careful.
That's what I was about to say. It's old till I reach there.
I'll start. I would just start by asking the question, is this new? Is this a new injury or not? We always need to, especially in older patients, they may have had a history of prior trauma, or they may not even know it. And so I would look really closely at the x-rays and the MRI before making a decision.
Good point. Would you be able to see a stump like that at a much later stage, say maybe about 3 months or 6 months? Would there be a stump like that seen?
Yeah, that was an interesting image. Sometimes you don't see it at all, and it's there. It's a good point, but I would look at the styloid itself, and there's a little something at the radial styloid.
Yeah, if you can go back, Nikita, there is definitely a little sharp point there.
Yes, so that concerns me, and so if I'm going in, I always have a plan B, and so I would definitely discuss that with the patient and make sure we're on the same page if it's old.
Do we have x-rays of the other side?
No, unfortunately. No, unfortunately not. I don't think so. Yeah, can we go on, Nikita?
Okay, so intraoperatively, we found that, like we saw in the MRI, there was a good stump of the scapholunate ligament, which was attached to the scaphoid. And on performing the Watson's test intra-op, we could reproduce the clunk because of the dorsal subluxation of the proximal pole of the scaphoid. So we went ahead and repaired the ligament with a suture anchor in the lunate, and we augmented it with a capsulodecius and 2 K-wires from the scaphoid to the lunate, like a scapholunate K-wire to reinforce and stabilize the joint. At 6 weeks, the scapholunate angle looked like it had been successfully restored, and the space between the scapholunate joint was reduced. That's the pre-op X-ray where the scapholunate joint looks looks higher, whereas in the post-op X-ray this is at 7 weeks, the scapholunate relationship is maintained. The patient is still in early rehab, so we don't have any pictures of his good mobility. He's just started rehab out of his cast and has started rehab. So the dilemmas in this case were, like, most of the studies, most of these injuries are seen in young active individuals, and most studies have very few patients in this age group. And also there is very sparse information about acute injuries in this age group. So our treatment options were first a repair. Literature has shown that repair at an early stage gives a good functional outcome in these patients. Whereas literature on reconstruction, primary reconstruction showed that in this age group, as opposed to a younger age group, the outcomes were not very satisfactory. And the next question is, do we consider primary salvage procedures in these patients? Like Dr. Cassidy pointed out about the the sharp edges of the radial styloid, and considering the age of the patient and the age-related cartilage changes, do we consider a primary salvage procedure in this patient? And if yes, then what would be a procedure of choice? So a PRC, this study by Dr. Peter Stern and Dr. Elfer showed that the outcomes of primary proximal row carpectomy in scapholunate dissociations were not very good. The age range was around the same age as our patients, and 9 out of 31 patients continued with analgesics because of severe pain. The post-operative functional range of motion was not as good and was quite low as compared to that of the contralateral side, and there was severe reduction in the grip strength of the operated hand as compared to the contralateral side. And also 4 patients had to undergo a total wrist arthrodesis because of the pain.
Nikita, did you consider arthroscopy first before you did the planning?
No,
that would have given you information about whether the ligament was repairable or not. So suppose you had done an arthroscopy and then proceeded from there.
That's a good point, yes.
But in spite of seeing a good stump on the MRI, would you still suggest a diagnostic arthroscopy for this patient? Or?
I would think so, as part of our treatment protocol itself. Scope it, and then you can open and repair, or if you're good at scopic fixation, you can go ahead and do that also, isn't it?
So you are still in favor of a repair in spite of the radiostyloid?
Absolutely. I am older than that old man. So I think 54 is just a number, and I would definitely want my scapholunate ligament to be repaired.
Yes, I strongly agree. I strongly agree with Binu.
Also, not think of salvage as such. You can always think of a reconstruction because it's still 54 instead of going to the 2 extremes of repair versus salvage.
No, Anil, the thing is the condition of the cartilage as you age. These injuries, you don't see them so commonly because I'm sure that when you go past this age, your radius fails before your scapholunate ligament does.
No, what Binu was making the point was that you scope and then you check, and then if the ligament didn't look good, then we can always have an option of reconstruction rather than thinking of a salvage.
Yes, of course. If you're doing a scopy, yes, 100%. There's just no question about that.
There's one thing that puzzles me about the case is you go back and look at the lateral film preoperatively, right? You don't, the lunate still looks like it's in neutral. And I'm having a little difficulty comparing the pre to the post-op because the forearm rotation is not exactly comparable. So, every scapholunate dissociation does not lead to a DC. We know that because of secondary constraints taking over. So I wondered, what were your findings when you did your capsulotomy? Did you see any difference there? And did it influence, because you said did a capsulodesis. So what becomes interesting is how did you make your capsulotomy, and what capsulodesis methodology did you use?
The part of the capsule that reinforces the dorsal scapholunate ligament was quite good. So we with the anchor we reinforced it. I mean, we usually use with these anchors along with the ethibond, we add an additional 40-proline sutures, which we then use to suture the other soft tissues and reinforce the repair. So that is what we did in this patient. And intraoperatively, the scaphoid looked quite unstable. I mean, and like we saw the Watson's test when it was performed on table, it looked like the scaphoid was very unstable and it was subluxating posteriorly.
So you are reasonably convinced that was acute?
Yeah, because he did not have any history of injury in the past, and there was no pain or any symptoms before the trauma. I mean, the trauma 1 month back.
Right. Oh, that's
Yeah.
fascinating. That's wonderful.
And quickly, if you can go on, skip the there's just one question about the next one. So if you can quickly go on to that.
What if the patient is 73 years old, extremely active, is a regular, goes to the gym regularly, exercises regularly, but has comorbidities, has been symptomatic for quite some time, and recently has started taking painkillers regularly, but he does not want to lose his movements. And he comes to you with a stage 3 SLAC. So what would your treatment of choice in this patient be? In a country like India, where total wrist arthroplasties have not really taken off, what choice of treatment do we have for these patients?
I have one question for you. What is the life expectancy of an average Indian male?
It was 65 or 67 when I last considered this for the CMC joint talk that I gave for the American Academy, I think. Or the ASSH, was that?
So
Yes, I think. Yes.
Yeah.
Yeah, so he's clearly defied the odds already.
Oh, yes.
In this one situation, I would consider the rassle. Just put a screw in the.
But
Binu, the point. Sorry.
Sorry,
Yeah.
Sudhir, go ahead.
Go on, Sumedh.
No, it's just 73-year-old bone doing a rassle. You need purchase on both sides, isn't it? It's
Okay,
not
that's about
hold, even in the most optimistic circumstances, I think.
The lunate does have a cyst over there, and the reason I put this up is simply the fact that what if you had something like this come to you at that age, but an active person, where the usual salvage of 4-corner fusions or an STT fusion is not available to you, and you are in a country like India, where total wrist arthroplasty isn't there.
A supervised neglect.
That's what I'm doing right now, but I need an answer to this one.
No. So Sudhir, this
Yes.
is not a scapholunate dissociation in the real sense of the word. This is either degenerate or related to CPPD, one of the two, and they behave very differently. So if you were to splint him and inject him, I think he'd be just fine.
He's doing fairly well. He, in fact, was a boxer in his younger days, an avid boxer in his younger days, but did have pain off and on in the wrist. But he's been seeing me for the last 5 or 7 years with this kind of a wrist. Now, if we needed to fuse both the wrists for pain, because he's now on pain medication almost constantly, and how would you fuse him? I mean, in what positions are you going to fuse both the wrists?
Why would you want to fuse him? Why can't you do a PRC with capsular interposition arthroplasty?
That's my point, that if the cartilages are not good enough and we see a cyst in the lunate on the right side, you can definitely see a cyst.
On the left side in the capitate too, I think we see a cyst. So would the status of the cartilage on the capitate be questionable?
Which is why I said capsular interposition, because that's the beauty of it. It disregards the capitate cartilage.
Right.
Right. I'll be even more nihilistic and just ask, where's the pain? So it may be an obvious question, but sometimes not. So if it's at the radial styloid, the PIN-AIN neurectomy is not likely to work. You can do a neurectomy of the radial sensory nerve branches, which I don't really like doing. But if it's central wrist pain, you may get good relief from a neurectomy.
So has he undergone a metabolic workup, as Chaitanya was seeing, bilateral and other kind of work?
He's just full of everything that you can think of medically. He's got a whole bunch of problems. So, I mean, there's very little that we can actually do for him. He's of course refused surgery. That is why he's still, I get x-rays every 2 years or every year, but really he doesn't want any form of surgery anymore. He's been through many surgeries for other reasons. Anyway, that's just one of those dilemmas that I was wondering about. If you need to fuse 2 wrists, how would you fuse them? Any thoughts on that?
So I wouldn't, but if you needed to, one would be at neutral and one would be in 15 degrees of extension.
Mm-hmm. Becky, any inputs on that, Becky?
In terms of fusion?
Yes. 2 wrists, if they're going to become stiff, where would you like them to be?
Yeah, that's a really good and impossible question, in my opinion. And so I think I would, if I had time, and if we had time to do it, what it's really great to do is to kind of try some really robust immobilization of patient in different risk positions so that they can try some of their activities of daily living with those splints on. I think it depends a little bit on what the patient does. Like what are their activities of daily living? What is their work, and what will they be successful kind of in a range? If I had to guesstimate, I would say, 20 to 30 degrees of wrist extension, but I don't think that's perfect for everyone. So I think it's a very tricky question and maybe more patient specific than we realize.
Yeah, Sudhir, this is where you say you are 73 and you don't need any surgery, maybe.
Those are great points. I think we have some experience with rheumatoid patients. And there's something that patients don't tell you, but it's self-care. And self-care requires some wrist flexion, actually. So I would say if you're going to fuse both wrists, one would be a little bit of flexion. But I like Becky's idea of testing it out first.
Dr. Cassidy, that's great. It's a really great point. And the adaptive equipment for self-care is awful. Like it's really, none of it works incredibly well. So I think it is a great point of thinking about self-care, and also even trying to retrain people on self-care is a very difficult task. And so that's a really excellent point to make as well.
Yeah, we did see some of these patients when I was a student, when we saw the effects of smallpox and on the elbows. And we did fuse a few of them, and both the elbows being fused and things like that. So that's what brought this thought to my head, that if the wrists need to be fused, then how do we go about it? Okay, thank you, Nikita. That was interesting. And now we go on to the last case. This case is going to be presented by Dr. Rohan Habbu, who's been taking care of all the questions quite happily, who is a young and upcoming hand surgeon who trained in the University of Minnesota and the Twin Cities Regions Hospital. And I wish I was young like him. He's learning the guitar and Latin dance. Wow. Rohan.
All right. Dr. Warrier, can you hear me?
Yes, quite clearly.
Okay. So I'll be quick and brief. We present you a 32-year-old dominant hand involved housewife with right wrist pain on and off for the last 2 years. She had progressive terminal restriction of the wrist movements. However, she was never investigated for this. She was able to do all her activities of daily living without medications, and no previous imaging is available. 2 days prior to presentation to clinic, she had a fall on the same hand. And this was her picture in the clinic. Obviously, there's a distal and radius fracture, which is displaced. And there is also a Kienbock's disease at the same time. A closed manipulation was attempted with a below elbow cast. However, this was not successful. So the dilemma or the issues that we have is there is a distal radius fracture that needs to be addressed. There's also a Kienbock probably at stage 3B. We have elicited 6 points between these two dilemmas, and we'd like to go one by one, addressing each faculty. For this particular case, do we need any further imaging? May I ask Dr. Binu Thomas his opinion on this question? Dr. Thomas?
It is giving us enough information about the condition and the fracture, but if you want further imaging, you can do an MRI to confirm that there is a Kienbock's disease, or a CT scan for your evaluating the distal radius.
All right. So we went through the literature. We didn't find anything associated with imaging for these two conditions at the same time. And like Dr. Thomas said, probably if you want to go ahead with any further imaging, it would be probably for the diagnosis and the prognosis for the Kienbock's disease. Our next dilemma was whether we treat only the distal radius fracture or whether we treat both at the same time. Dr. Cassidy, your thoughts on this?
I'm sorry, was the patient symptomatic before the distal radius fracture?
Right. She's been having this mild to moderate pain in the wrist on and off with progressive restriction of movements. However, she's able to do all her activities before this particular trauma.
So I alluded to a paper where the surgeons performed an osteotomy without a shortening and just put a plate on it. So she has already done her own osteotomy, and I would just put a plate on it. And she's going to do great.
All right.
I wouldn't treat the Kienbock otherwise.
Okay, all right. So again, going through literature, we found a couple of papers. One of the papers that Dr. Cassidy referred to, then this was the other one. This one mentioned any surgical procedure near the lunate induces changes in the arterial inflow and the venous drainage. So probably doing something to the radius might help in her Kienbock. Dr. Grewal, do you have any idea or any experience whether distal radius fracture works like a decompression for a Kienbock disease?
I think it is certainly going to have the same biologic effect where, like you mentioned previously, it stimulates the blood flow to the area. I agree that I would only treat the distal radius fracture. You could even argue whether it needs to be plated or if she can just be treated in a cast. And if you were going to do an ORIF, just make sure that you don't over lengthen it. Normally when we do a radius ORIF, we want to try to get the length out, but for this one, you may be happy just even keeping her at neutral variance.
All right. So we did find some indirect evidence of whether distal radius fracture works like a decompression for the Kienbock, and these were some of the papers that we found. Dr. Sumedh, do you have any experience on outcomes of distal radius fractures on the Kienbock disease? In the sense, do you see it getting better or do you see it getting progressive? Dr.
Sumedh has left, I think.
Okay. Dr. Mudgal, could you take this question?
Repeat that, Rohan.
Okay, so this question was primarily is whether the distal radius fractures, does it change the outcome of a Kienbock disease? This is probably stage 3B. What if it was an earlier stage? Will it change the outcome?
It might actually help. So if you look at the original history of Hilaire-Mendy procedure,
okay.
It was born out of distal radius fractures in patients with Kienbock. And that's how he came up with the concept of core decompression, where he found patients who presented him with Kienbock and later developed a distal radius fracture actually went on to do better. So
okay.
much like Chuck said, I would treat the distal radius fracture on its own merit, and it's very likely that the Kienbock will do okay.
All right. I guess this question was probably answered by all the previous faculty, that whether we do a surgery for the Kienbock or the distal radius. And I think the answer is there. Treat the distal radius on its own merit and observe for probably the Kienbock disease.
Yeah.
Is Becky there? I wanted her to answer this, whether the rehabilitation after doing something for the distal radius, will it be any different when there is a Kienbock disease present at the same time? Becky?
You know, that's a really good question. And I think it's a little bit of a stumper question. I would love some help from the surgeons on this. In my opinion, I would think about whether there's any pain. If we're monitoring all the typical components of a really good comprehensive assessment with pain and range of motion, any type of sensory issues, I would hope that if there were any kind of negative effects of initiating range of motion, you know, after a distal radius fracture, we certainly want to begin motion as soon as possible. We really think about kind of synergistic motion as a means by which to enhance grip. But I would want to know if any of those types of interventions are going to cause any increased pain. And so I don't think it would, but I would love the surgeons to really jump in on this to tell me if I'm wrong or maybe have a different opinion.
All right, so we actually couldn't find any literature supporting or disproving what sort of rehab should be done. Anyone in the faculty could take this? Dr. Cassidy?
Sorry about that. I would be concerned that prolonged immobilization would result in more stiffness than usual in this, with this type of problem. So I would like to, within tolerance, have the patient start moving the wrist early.
All right. So we ended up doing a distal radius fracture fixation, and like the consensus of the faculty, the Kienbock was left alone. This lady was immobilized early for the initial part and then mobilized. And this was a range of movement at about 4-month mark. She has some stiffness. We don't have any pre-op range of movement, pre-injury range of movement to compare, but this seems to be, she seems to be doing good.
Rohan, would you not like to take the opposite side X-ray, as Ruby was making a point of having a neutral base? I mean, if you see the X-ray now, it's slightly positive.
Okay, I think that's a good point. We hadn't seen this much in my experience. This Dr. Warrier's case, hopefully he could shed some light on what's his experience on this combination per se.
No, I haven't taken the X-ray of the opposite side. I mean, next time she comes, if I can convince her, maybe I'll get an X-ray to just look at that.
Yeah.
But the problem was that I don't know. I've never been faced with this before, ever in my career, and suddenly this thing comes up, and I have questions. All the 6 or 7 questions that Rohan asked were just being churned through my brain, and so I said, "This is crazy. I want to." The Kienbock is calling out to me and saying, "Do something for me." Now, do I do it at the same time? Do I do it later? So, but it seems to be doing well. We just chose not to do anything to that, and it seems to be doing well. And I hope Illaramendi was right.
Do you think you're going to put a couple of drill holes into the lunate while you're...
I think there's not much of a lunate left there. It's just a collapsed piece of very mushy stuff. Yes, Pankaj.
Yeah, so when we now know that there is a lunate which is almost fragmented, and now we are no longer dealing only with the lunate pathology, we are now dealing with a collapse that has already happened. So we know by natural history that maybe 7 to 20 years, this could potentially become arthritic. So even if we don't do anything now, would you not discuss these possibilities with the patient and give the patient an option if something like a PRC could be done at this stage?
No, we did. I spent a lot of time with this patient, trying to explain to them, and it's impossible to explain to a patient who's had really nothing much to go to a doctor before she had the fall. And then suddenly you tell her you're in stage 3A or B or whatever. It sounds like cancer of the highest order. And suddenly you're telling her that your wrist is all bad and I need to do this. And she says, but I was doing everything. So it took a long time to discuss this with the patient. I did, for a moment, think about doing both the procedures together. And then immediately threw that out of my mind. I said, I can't rehab this one at all once I have both sides of the joint affected. So I said, I'll do what's necessary and hope that there's some difference in the decompression theory that helps me to move on. And the only thing that probably I have kept in touch with the patient is to keep coming back for follow-ups. So as soon as I find that things are getting worse, maybe before it gets too bad, we take that step and do a salvage surgery. But yes, you need to sit down and talk to these patients for a long, long time.
I think you did the right thing. And just to follow up on the question, the follow-up of the free osteochondral grafts for Kienbock by Higgins is less than 2 years. So aside from that, the natural history of radiographically of Kienbock is progression, regardless of treatment, with very few exceptions, right? So joint leveling procedure, any of those procedures, the x-rays are going to worsen over time, but it doesn't necessarily correlate with patients' symptoms, right? So the natural history is that the patients in general, their pain does subside, although they may be stiff, like this patient had some limitation in motion, but they don't correlate. So that's where my nihilistic philosophy about this has come around.
Ruby, you wanted to say something.
Yeah, I was just going to say, if she didn't fracture her wrist, you would have never met her, right?
Exactly.
Yes.
You don't know how many people there are like her walking around
Yes.
with this problem.
Yeah,
So I think you definitely did the right thing just treating the wrist fracture alone.
Yep, absolutely.
Yes, Rohan.
There's one question by Dr. Shrikant from CMC Vellore. Apart from the plating, would a scaphocapitate pin, just pinning the scaphocapitate, would it have done any difference?
I think I would echo what Ruby said. If she hadn't broken her wrist, you would not have met her. So don't treat the X-ray, treat the patient.
Okay. When we were going through the literature for this, there was one paper which Dr. Chuck actually mentioned. They just did an osteotomy and then refixed the radius, and it showed good results. I think few of the cases were advanced stages like these, not many. I think 2 or 3 cases were 3B. The rest of them were stage 2 and maybe earlier, and they had good results. So maybe there's some evidence that breaking the distal radius might help the Kienbock. Let's see.
That's what my mentor, Dr. Jupiter, does that. He doesn't do an osteotomy. He cuts the radius and puts a plate on it. He doesn't break it completely.
Oh.
So,
right. I think, Chai, it's time is getting on, and we could go on and on about each and every one of the topics that we did. Thank you very much for giving me this responsibility of putting together this wonderful, wonderful module.
Sudhir, you've broken the record.
Yeah. This was fantastic. Sudhir, Anil, Binu, and Pankaj, thank you for being part of my core team. And Chuck, Becky, Ruby, Sumedh, Rohan, and Nikita, thanks for helping out and being such great participants and giving so much knowledge to all of us and our attendees. Thanks to our attendees for being so loyal and being with us again. And our sponsors and OrthoTV, without whom we could not have done any of this. Next week will be the last session. It's on elbow, and we should have another fun-filled session. So I hope all of you join in. And until then, thank you and enjoy the rest of your